Well, good afternoon. We'll start the final session. I'm John Isaac from the UK. Catherine Tay is not here. We have Lawrence. Catherine Tay.
I am an avatar of Catherine Tay.
Also known as Lawrence Sheesh. So we will have the program start. For every case, we'll have a discussant, as this morning's, just like this morning. We'll have the discussant continue after the presentation, and then we'll open to the floor for discussion. Okay, so we'll call upon Valerio to give the first talk, and that's a rectal tumor with synchronous liver mets with chatitude.
So thank you very much. First of all, thank you to Mr. Bismuth, to Guido Torzilli, to Ugo for taking my presentation to present to the Compagnons. So it's a study, the RECCILIMET, which is the acronym for rectal cancer surgery with synchronous liver metastasis. What resection strategy should we perform? So it's first, we know that rectal cancer, 20% of patients have synchronous liver metastasis, and the guidelines, the published guidelines from the ESMO and from the ASCO still say the scheme of chemotherapy followed by radiotherapy, rectal surgery, and at the end, liver surgery. And of course, the aim is to have a complete resection to increase the overall survival. And already 15 years ago, the Compagnons from Geneva proposed the inverted strategy of liver-first strategy with very interesting results. And so nowadays we have three types of strategies available to face those patients. Rectum-first strategies, where we have to be assured to have a symptom control, but the problem is that the morbidity and the ileostomy may render more difficult the resection of metastases that may become unresectable during the waiting period, and we have the problem of hepatotoxicity. Then the inverted strategy, where we begin with liver surgery, there is no problem of, or less problem of missing metastasis, and the criticism of the colorectal teams is sometimes that rectal surgery may be more difficult because of more adherence and more difficult mobilization of the colon. And then the synchronous approach, of course, there's an advantage of length of stay in the hospitals, of costs, but of course it's only limited to a very small amount of patients where the surgical complexity is low. So the aim of our study was to verify in those three types of strategies what is the complete resection rate and a secondary endpoints if the liver-first strategy does hamper rectal surgery, and so is there more anastomotic leak? Is rectal intraoperative and postoperative outcomes the same if they underwent liver surgery before and not? And if the morbidity and the mortality of rectal surgery is increased with the liver-first strategy. And so we underwent the work is done by an assistant who, for his end of residency, made a work between our hospital in Brussels, Erasmus Hospital, and the University of Padova, but the colorectal centers, not the HPB center of Padova, a 10-year experience, 2010-2019, where we selected the patients who underwent the three strategies. The inclusion criteria roughly was all medium or low rectal cancer which needed radiotherapy, so T3, T4, and plus tumors with liver-only liver metastasis, so no pulmonary metastasis, and no other locations, and that the resection was planned with a clear strategy. So the exclusion criteria was all high rectal cancer, all the transanal approaches, and the presence of other metastases. So roughly from 800 patients in both centers who underwent rectal cancer surgery, we end up in the Italian center with 16 patients who underwent, who were included in the study, and in the Belgian center, 29 patients who were distributed in this way. We see that we have 13 patients who underwent rectum first strategy, 20 patients who underwent liver first strategies. They were all in the Belgian center, and 12 patients who had a synchronous approach. And so we see that the liver first strategy were all done in a liver first interval approach. It means that they underwent the liver surgery at the end of long course radiotherapy. Now, until a couple of years, we don't do any more long course radiotherapy, but short course. But all in those patients were all with long course radiotherapy, and the liver first strategy was done at the end of irradiation. So looking on the results, so the three groups were roughly similar, just the liver first patients were a little bit fatter than the other, so a higher BMI, statistically significant, and the other factors were all similar. Concerning the tumor characteristics, also there, no statistical difference. We see that we had quite a high number of metastases, a median number of 5 metastases, and 62% in the rectum first and 75% in the liver first strategy were bilobar locations. So concerning the results, complete resection rate was, it means that the primary tumor and all the liver metastases were finally all resected, was of 85% in the liver first and in the synchronous approach, and of 62% in the rectum first strategy, but statistically no statistical difference, even though there might be a tendency for a better results for the liver first strategies, and so the same numbers as the first publication of the Geneva publications. Concerning the survival, same survival for the three groups. So no statistical difference in survival, and of course, patients who did not achieve a complete resection rate had a statistical worse long-term survival compared to patients who reached a complete resection rate, which is quite logical. And concerning the secondary endpoint, so does the liver first strategy cause a more difficult rectal cancer surgery? So we had a quite high anastomotic rate, but they were all grade 1 fistula, so no treatment needed, and were all, I think, almost all asymptomatic fistula, which were visualized by enema at the control before closure of the ileostomy. And so the three groups had roughly the same, so no statistical difference between the three groups. And concerning the operating time and the complications, also there, similar results between the rectum first and the liver first strategy, except for length of stay after rectal cancer surgery, where there was 1 day difference in the liver first strategies, very probably because of different habits in the postoperative follow-up of those patients. Concerning the overall operating time, we are talking only of the rectal cancer surgery, so a shorter total operative time in the synchronous approach, of course, compared to the rectum first and liver first when we add the two times of rectal and liver surgery. So there was a difference, and also in length of stay, the cumulative length of stay of liver and rectal surgery for the rectum first and liver first groups, and shorter, of course, for the synchronous approach. For the rest, no difference. And concerning the oncological resection of the rectal cancer, also no difference between the groups. Same number of retrieved lymph nodes, and say roughly the same R1 resection of those cancer. The follow-up was also quite similar. No operative mortality, and long-term complications were the same in the three groups. Long-term complications roughly are éventration, I don't remember the name, or parastomal incisional hernias. So, of course, this is a very small study, retrospective, a small sample size, and of course very dependent on local practice, but we had a very strict inclusion criteria and a long follow-up and a validated protocol by both ethical committees. So in conclusion, we didn't see any significant difference in complete resection rate between liver first and rectum first strategy, even though we saw a tendency for a better results for liver first strategy, and concerning the secondary endpoint, we didn't see any factor that shows a more difficult approach of rectal surgery after a liver first approach. So I was wondering if we could do a companion selection of those patients, and if centers want to participate and retrieve those patients. We don't have normally a lot of patients per center, so it was a question if it could be interesting for our centers to participate to a common retrospective study. Thank you very much for your attention.
Okay, we'll have the discussion. Yeah, Guido Costa.
Thank you. Thank you, Dr. Lucidi, for your presentation and for your study of a current topic. I have just two questions. One of them is on the strategy selection criteria of those patients. You said that one group of the patient did all the liver first surgeries, and the other center did almost all the simultaneous resection. And you showed us that there is a non-statistical difference, but there is a difference in the number of liver mets resected. So just wondering if you can comment a little bit on how these two groups selected the patient for the two operations.
So, of course, there is a big limitation of this study, because we compared the attitude of a more hepatobiliary center with a very good collaboration with our rectal cancer surgery. So all our decisions of resection of liver first strategy was on a multidisciplinary setting with oncologists, rectal cancer surgeons, and liver surgeons together. And the selection is for multinodular, mostly bilobar tumors. We try to favorize liver first strategy at the end of radiotherapy, chemotherapy and radiotherapy, of course. And in the Italian center, it was, I think, I don't know them, so, but I think it's mostly a colorectal center, so which is not the hepatobiliary center of the same university, and so quite a different approach, because they favorize simultaneous resection or rectum first resection. So the selection, I think it's also done in a multidisciplinary setting, but of course with different decisions.
And a second comment, yes, on your primary endpoint, you showed us that you had a lower complete resection rates on rectal first patients. So if you can comment what happened to those patients that did not reach a complete resection after the rectal surgery, and if you have any information on those patients who did a liver first and did not have a complete, because if I understood it well, you started selecting patients based on the rectal resection, considering the patient that did receive rectal resection.
Yes,
okay.
yes. So, yes, we started from rectal resection, but we so in the Belgian cohort of patients, roughly we took all rectal cancer surgeons. So it's a limited amount of patients, because had to have radiotherapy, had to have liver-only tumors, and of course resectable. So non-resectable or marginally resectable were not included, and for the selection of the Italian cohort of patients, I think they took all patients who underwent rectal surgery and liver surgeons. So probably there is an amount of patients who is not picked in the study. But normally, this was a selection based at the time of rectal diagnosis with liver metastasis. So, and this is where the time where we included them. And so the patients who were not resectable at the beginning were not included in, for liver not resectable were not included. For the questions, what became the patients who were not completely resected for, so the patients who had a liver first strategy is the patients who recurred very fast after the liver surgery. We have two patients who had resection and a thermal ablation and had a recurrency at the border of the thermal ablation, which I also don't like Guido. And so those have been classified as non-complete resection.
Thank you. Is there any comment or question? Yes.
Yes, this study is very interesting, and we have to state that all these patients has a synchronous disease, and all these patients need chemotherapy before the treatment. And in different series, more than 80% of the patients respond only the rectal of the liver just with chemotherapy. Maybe most of the cases you don't need radiotherapy, because when you apply radiotherapy, you have to stop with the huge chemotherapy. Second one, when we speak about rectum surgery, we have to speak about specialists, because middle or lower rectal surgery is just for specialists, it's not for general surgery. The same for complex liver resection. So one of the limitations when you're speaking about synchronous disease is that you need two specialists if you want to have good results, as good specialists in liver and as good specialists in colorectal liver surgery. The third comment is that when you are selecting, you can have a huge hepatic disease. In this case, maybe you have to apply the liver first. And maybe you also can apply, we have in 10 years 53 patients selected for simultaneous rectum and liver resection, but we operate with specialists in colorectal, and all these patients had been discussed in a multidisciplinary way. So you say that you have 2 patients that they can't complete the rectal resection, or that means that the margin was positive?
That the margin was positive.
The margin was positive, but the surgery was complete. So I think that we have to think in that. Sometimes the complex surgery is the rectal, but and sometimes the liver is easy, but to drive a plane with 4 turbines, that is middle rectal and lower rectal, is not the same that high rectal disease that is a plane just with 1 engine. So you need very good specialists. It's the same for liver.
I totally agree with you. So in our team, the rectal surgery is done by the colorectal surgeons specialized for this, and they do, so all resections are done by laparoscopy or robotic, and so it's 2 different teams who operate those patients. So we, as HPB surgeons, we don't operate those rectums, so it's 2 teams. It's also probably the reason why we do very seldom synchronous approach for rectal surgery. So I totally agree with you. It's 2 different specialists, and we take the decisions together. So it's very important to work together. And some patients who underwent rectum first surgery didn't achieve final hepatectomy because of evolution between the waiting point. And all patients had chemotherapy. And you were talking, your question was on radiotherapy. All those patients needed radiotherapy because it were only T3 and T4 and plus low rectal cancer. So radiotherapy is advised for those patients.
Okay, the comment of Eduardo shows that it's a debate from a long time, and the problem is that there is a lot of factors, and we have to discuss case by case. And first, you have to see if they respond to chemotherapy, and after this chemotherapy, sometimes there is a lot of change because there is nothing in the rectum. And it depends also of the discussion about what is the healer. I mean, if it's the rectum, it is the liver. And we can say that this liver first strategy was really convincing a lot of years ago, because rectal cancer surgery was really morbid. It has changed. Sometimes they do just watch. Sometimes there is a laparoscopy, robotic, and it's changing also. So I don't think that such studies could help, because it's so heterogeneous. And I see young surgeons, I think it's confusing for them, because, well, we don't know what to do. And I think that case by case, because you have 12 and 30 patients in group, it's very small groups, and they are not the same patient, you know that. So I think that I agree, it depends on a lot of factors, case by case.
You know, as Angelita Abrangama from San Pablo has demonstrated, 15% of the patients that receive chemotherapy in order to reduce the liver disease have not disease in the rectum when they explore. So if you start with the liver and you study and maybe you have a huge response to chemotherapy, maybe sometimes you don't need to operate on the rectum.
That's exactly what I said. Okay, thank you. Another comment, question? We can move on, and it's a real pleasure for me to introduce Guido. Speaking of what? Parenchyma sparing surgery between stage hepatectomy and liver transplant. What a surprise.
Yes, because, you know, I have already ready this presentation. I have to take care of all these patients. I cannot introduce a new argument. So, but I think there is something new also here. At first, thank you very much, not for the invitation, because it's but for the consideration. So, at first, the background of the talk, and every one of you agree the target is the R0 world. And this is a review paper by Petrowski and Pierre Alain that published on Lancet Gastroenterology and Hepatology, and it was shown the panel of R0 resection, in which there were many figures representing the multiple bilobar in the staged procedure. The margin is one of the issues that has found some debate in the years, and still now is an object of debate with the introduction of the R1 vascular, and most of you agree to the fact that R1 parenchymal is something to be cancelled. But in the fact, in the history, if you see, the surgeon has always been attracted by the tumor edge from more than 1 centimeter. It was an irresistible temptation to expose the tumor, and there was the 1 millimeter. You know, 1 millimeter is difficult to be considered and measured. And also the literature was always more and more looking at that. Probably it would have not been really a disaster like in this case, but there could be some room for long-term survival. And René showed us that by necessity, the results were everything but not bad, because they were almost similar in terms of long-term survival to R1, And this was the R1 totally considered. This was a survey that we did among several centers in the world, and by necessity, more than 50% did agree about the use of the exposure. And this paper from Nick Vautet, that is going to come, he couldn't because his flight was cancelled yesterday, so now he's going to arrive in Milan, I guess. He was showing that, look, less than 1 millimeter, the recurrence rate was similar to the other. These were papers in which there was not a distinction, but anyway, we can say that by necessity could be also accepted the R1 parenchymal, still not, if not green, it is at least yellow. But as we discussed, there is also this fact, this is a different pattern, you know, and the hypothesis I disclosed many times these days, different anatomical part, so different concept of recurrence, and the possibility to make the detachment of the tumor from the veins and the Glisonian pedicle. And as it was mentioned, the anatomy induced us to be optimistic in this sense with the Laennec capsule, which was not discovered by us, but we took profit of this fact, according to the paper of Sugioka. Then we started detaching the tumor from the hepatic vein and the Glisonian pedicle, and this was the first paper that was showing our series of one-stage hepatectomy, in which the reviewer, to allow me to publish, asked me to cancel the overall survival. I don't know why, but I couldn't refrain to be accepted this paper to come out in the literature, and then I accepted that. But we did the paper that was published later on with the larger series 727 areas, 226 patients, and the R0, R1 vascular were behaving almost equally on a long-term series in intention to treat disease. If we focus on the hepatic vein at the caval confluence, as I was mentioning, look, the partial resection was in 1/3 of the patient. Half of them were just detached, and a few of them were patched. You may ask, what about the other? I will explain later on. Then we can say that R1 vascular, at least in our perspective, is fully acceptable in terms of oncological suitability. If you talk about the R1 vascular, when it doesn't work in the case in which you cannot save the vessel, the liver provide the solution itself. Look, this patient with the 3 huge tumor, the one here is in contact with the right inferior here, and it was invading the middle hepatic vein. Then we have to amputate the vessel here and detach here. These are the resection areas. And at the end, there are the collateral circulation in this case that can be confirmed intraoperatively. This is the right inferior, and there was a collateral circulation with the middle hepatic vein. We have to divide the middle hepatic vein here to keep the collateral in between the right inferior and the left, and at the end, this was the collateral confirmed. This is the point in which we have to divide the vessel almost into the tumor, and this is the results. This is the right inferior. This is a tunnel. There was a detachment with the hilar plaque. There is only the left hepatic vein here, and the middle and the right were divided, and partially the inferior vena cava was sutured by resection, and there was another R1 vascular on the left side with the left hepatic vein. That in this way, you can do conservative surgery. We may say not really a minimal resection, but with sacrifice of the parenchyma, keeping the scaffold of the liver in almost all the patients. And if you assemble all this kind of approach, you can obtain good results. Moreover, because nowadays you can estimate, even in front of disease that demand a very complex 3D resection, you can estimate precisely the liver remnant, which is a big advantage, and has allowed us to push further our resection amount. Then in front of a case like this, the rules are recognize the cluster, identify the deeper lesion in contact with the vessel, and those at the periphery of the area. Once you have done that, cluster compass points, you figure your resection area, and you carry out the resection, leaving in this sense a slice of liver. If you look this liver after 3-4 months, it will be very big, completely recovered. And so you spare a big amount of organ, because with the in and outflow perfectly done and the biliary drainage too, believe me, it's very nice, and there are several operations that you can introduce in this modality. We say parenchyma sparing major hepatectomy, and this is one of the main criticized for us, the reproducibility. This is a case of huge involvement. This is the same after chemo. This is the liver cast. And these are the area drawn. And this is the resection. And this is the author, not me. So it can be transmitted. This is an operation done by us. And these are 2 operations. This is Dr. Sanket Menta. He stayed 3 months with us. And Ramiro Fernandez, he has never been with us in Peru, but he's following our attitude. Then it can be repeatable. And the comparison, I just want to recall that in that paper, anyway, R1 in most of the report is not rare, especially when you are facing with a high rate of metastatic disease bilobally, and if in most of the time, even in the left margin, you have to expose the tumor, and the mortality is not negligible. We did the comparison, and the comparison was showing that we had a better short-term outcome, and the survival or intention to treat is in favor of the parenchyma sparing because we don't have the drop out of the disease. We were challenged in this paper by the Italian Registry of Alps, and there was not the same complexity in favor of the Alps group, less complexity, 1 to 2 the margin. The safety was in favor of the one stage, and the long-term results in terms of outcome and disease-free were similar. And also, if you look at the recurrence-free survival, comparing the 2 stages and the 1 stage, they are equal. The salvageability is in favor of the major, the parenchyma sparing. This is a paper from Nick Vautet, showing that if you do a parenchyma sparing, you have a more chance of repeat hepatectomy, and even if you do advanced parenchyma sparing, like in this case, same situation of the sliced liver with this dissection plan, is another patient similar to the previous one. And at the end, this patient was reoperated twice. Anyway, the 66% of the liver-only liver recurrence in our series could be re-resected. And another criticism, in any case, R2 surgery, this is a nice paper that has been already accepted to the transplanted patient, 64% of them are undetected CLM in the liver that was removed. Then the transplant has a big rationality, also because of the good results once you are within the Oslo score, the Fong score, the SECA2, in terms of overall survival. But if you are out of the score, the outcome is a little bit worse. Of course, the disease has changed its behavior, more lung recurrence which are indolent. So there is a lot of rational transplant, but the problem is, up to now at least, the transplant is referred to, as also René said, to a minority of well-selected patients, and I agree. It is, of course, there is the value of the organ to be implanted, and the donor also that determine this strict selection criteria. And surgery, I may say, that collect his patient among those who are considered resectable, but resectability is a very vaguely determined situation, so it is very difficult to classify who are. Anyway, we operate the patient within the remaining 98% of patients with metastasis. So the less we cannot select the blue eyes, the blonde hair, and the tall guys. And this, furthermore, there is even room of attempt with surgery to go towards the less favorable patient, even those in with progressive disease, given the safety of a treatment, may have a benefit in survival, and with the inverse probability weighting, which will be a discussion between Gina and Dr. Famularo is the author of this paper about the machine learning and artificial intelligence. We saw that it was confirmed in a larger number of theoretical number of patients was confirmed this attitude of having anyway a benefit from surgery. Then concluding, we may say that our approach nowadays has had further confirmation. This was a very nice because it was very pleased with us. Sky Mayo on surgery commented the transversal hepatectomy about this kind of procedure. And in the future, I may surprise you, but if I see something that is fascinating before my retirement, it's this, and sorry, but no, just this.
Okay.
The printed liver.
The printed liver.
It may be with a transplant. At this point, probably I will have to surrender. Thank you very much.
So who's our discussant? Is he here? Fernando Alvarez, is he here? Yeah. Okay, we'll have a discussion now. Fernando, yeah.
Thank you very much. Well, Professor Torzilli, great talk. I am a big fan. Okay, so first I would like to congratulate you and your team, of course. Yeah. And your team, of course, for the great contribution you have done in the last 15 or 20 years in the not only the technical aspect and advancements of liver surgery, but also our understanding of tumor biology in liver metastasis. So that being said, I would like to focus the discussion on the most controversial topic within enhanced one-stage liver surgery or parenchyma sparing, which is R1 vascular resection. So I visited you in 2016, and I could witness how rigorous and meticulous you are in collecting data. So I believe what you have published, and in my own experience, since I've been doing R1 vascular resections, I could corroborate your results. But you published in 2018 a survey, a worldwide survey, in 270 surgeons from 51 countries, and despite half believed that R1 vascular was equally safe as R0 parenchyma, only 10% used it in a routine basis and 27% as per necessity. So still, we don't have that much acceptance as we would like to. So probably before you answer my question is how you could explain that. Is it the technical difficulties? Is the difficulty in breaking a dogma that we have been inseminated since a long time ago? And probably it could be, if the chairman thinks it's appropriate, we could update that survey, because we have nowadays here the Compagnons from all over the world, and we could have more updated data before you answer. So, and the other question is regarding R1 vascular. Did you find a difference in between R1 vascular in the Gleasonian pedicle and in the hepatic veins regarding recurrent survival? And is it equally safe, or you feel equally comfortable doing an R1 vascular in a patient that didn't receive preoperative chemotherapy and in one that received preoperative chemotherapy? Thank you.
I didn't propose the question. No,
But you're ready for the answer.
We are not discussing. But I am open to any question. Concerning the fact that 10% in 2017, it was 2 years later. It's not just detaching the tumor, it's also a concept of different way of dividing the organ and figuring the surgery. So it takes time, I think, and it takes also a decision or not. And I may agree that for robotic surgery, I asked one of my staff to do it initially, because I feel a reluctance to change my mind. So changing the mind at a certain age in a position of leaders, it's difficult. I cannot. The discussion is we don't have to be dogmatic against. And I saw that day by day, there was Oscar today that showed a fantastic operation in fully R1 vascular. As for the difference between Gleasonian pedicle and hepatic vein, it seems we have new results recently. There is one of my staff that is investigating these results, because now we have a big series, and it seems surprisingly that there is no difference, and it may behave better the Gleasonian pedicle. I may confess that I was expecting the other, but for the other, most of the time, we de facto excluded those who had some of them were not really detachment, but partial resection. So it's a salvage of, while for the Glisonian are only the real detachment, because the other were the amputation. So probably in this sense, you could explain the same results.
The question about chemotherapy, you're comfortable, but the question was, would you only do it after?
Yes, yes. The chemo nowadays, in our series, the entire series is 85% of the patient receive chemo period. Most of the time, the patients are not undergoing neoadjuvant, but they had insisted chemotherapy because we are judged unresectable. Not only by multidisciplinary barrier surgeon. Most of the time, this is a bad habit of the oncologists in many hospitals. They decide by themselves that is not resectable, just based on the number of the lesion. And sometimes, you remember sometimes also 5, 6, 7, 8 lesion. It means unresectability still now for some oncologists. So the majority have the chemo. As I mentioned before, once you have a big shrinkage, paradoxically, despite a small lesion, you have to, it's like if the tumor is gripped. And it depends also on the kind of pattern, growth pattern, replacement or displacement, and replacement is the one that is more difficult to manage and include and determine the higher frequency of vessel invasion.
A quick comment and 2 questions.
And then Oscar, and then Pierre Clavier.
Vas-y, Romain.
All right.
Oh, so the comment is that I think Guido should be congratulated to having been able to spread a technique which was considered as totally anecdotal. How many times I've heard, oh, this is only done by Guido Torzilli. What you demonstrate clearly in these 15 past years is that not only you have spread this into your team, but also you have spread it into other teams with more and more factual, I would say, convincing results. So congratulations for that. Now 2 questions. The first one is, do you make any difference between, I would say, R1 vascular on the hepatic vein and R1 vascular on the portal vein? Because this could be a little bit different. And my second question is provocative. By seeing all you are doing, it seems that the number of metastases is not anymore a problem for you, even 20, 30, and so on. So my question to you is, what do you think is today a good indication of liver transplantation?
So Guido, have you answered the first question about hepatic vein and I think that's, you said it's no difference.
I right. Said the data are showing that there are no difference, but I think also it's due to the fact that the real contact of the Glisonian pedicle results in amputation, so we don't see the real infiltration. So
the second question is liver transplant. We don't need it anymore, basically, from René.
No, I think that the liver transplant is, I am fighting with the management of this hospital because I want to see the possibility to start a transplant oncology program. Not for me, for myself, because it will take bureaucracy and whatever 10 years. So I am 60, so I finished. So I trust. I think it's a nice option. For now, is dedicated to a little part of. I asked to Paldac to do a study with us, with our patient, because I had one of their staff that visited us and they said, we don't even transplant this patient that you operate. And then we have to do a real case match for the really otherwise unresectable. I don't say that we are doing the miracle, but in example, double R1 vascular, most of the time, multiple disease is considered unresectable. For us, it's not unresectable. It's 30% of our series. So this is the match in between. But I am confident that I can step down immediately.
Hey, yeah.
Guido,
Oscar.
Congratulations once again. Really, I'm also a great fan of you. Two questions. The first one is, do you have different strategies between patients with RAS mutations or patients wild type? And the second one is, how do you plan the operation? Do you perform in the console of the CT scan? How do you
CT scan,
plan?
PET scan,
This is a multidisciplinary
MRI.
board with the imaginologist. How do you plan the strategy?
So the preoperative staging is always CT, chest, abdomen, superior in particular for the cast. Because the system we have does not allow to do the cast with MRI, that anyway we have to do. Because I want to do the Primovis phase and I want to see despite most of the patients, unfortunately, come from other hospitals, and the other hospital, especially the oncologist, sorry for that, but they don't recommend MRI. They use the CT, and we need the comparison between the same technique to see if there are really the same lesion and we can recognize any disappear, because if you do this surgery, it is important to monitor any disappeared lesion, because it may change. If you amputate, the organ is less important. And then every patient undergo the multidisciplinary team. Any patient that is addressed to the Department of Surgery, 100%. It's not the reverse for those who receive radiotherapy, oncology. They at first treat and they submit to the.
So that part about RAS wild type, RAS mutated.
We have published a paper. The results are not convincing to me. We published because it seems that R1's KRAS mutated protect against recurrence in the R1 vascular. But I may say that I want to investigate a larger number because I really do not. I'm not convinced of this data.
Mr. Clavian? Yeah.
Just a short comment. Number one, I think everybody can only congratulate for this extremely fancy, complicated surgery. Congratulate you because you're really persistent. I think coming with this, already you know a few people who seem to do the same. My call is again the same. If you compare from the ALPS registry stuff that 10 years old now with all the confounding factors, I think we never have the answer. I don't want to be, we will never have the answer. You have shown are feasible. I think that you've demonstrated. We have to agree with that there are some good results, some less good results, could be a bridge to trauma, but really a conclusive answer for patients with many tumors between two-stage hepatectomy and this one, I think we never have the answer. We can program debate for the next 20 years. We have no data. You cannot. And a randomized control trial would be almost impossible on the same way because that's different expertise. You have belief, you have expertise. Not everybody can do this surgery. I can guarantee you that most of the surgeons, and speak about HPB surgeons, they don't have the character, the patience, the knowledge, whatever, to do this. The ALPS is much simpler operation when we compare to that. I mean, it's relatively simple in some way. In terms of so we have no randomized trial, and if it's seen by other people of oncologists or whatever, they may laugh at us because we are just talking about technology, what we can do, but totally inconclusive. And without I think we can show feasibility, some long-term result, but compare one with the other one, I cannot imagine we will be conclusive. Maybe you can comment on that. It's not a question.
Yes, I am pleased to comment because there are tons of comparison between the stage and ALPS published elsewhere, also on the top journal, even though they were methodologically exactly the same that the one that I published on digestive surgery. And also there is a paper published on anastosurgery, radiofrequency plus and this paper was done to you by the Gustave Roussy because they were hearing that we were dealing the other paper that unfortunately wasn't. So the methodology is important, I agree with you, but none of this study, also those who are more visibility, have been proven anything. The problem is that if I read a paper on Nature Gastroenterology, I made a mistake before. in which the portfolio of the procedure, there is not this one, I just say, please, there is no proof, but there is. And then it should be discussed. I know, I take time, and then this is because I am enduring, because I am convinced, and I think that in the community should be considered a solution. It does not depend on because this kind of operation has started and proceeded with a level of safety that none of the two has the same. We can then, if it was not aborted, the other two, with such a level of complication that they were associated with for advanced disease, we are discussing about the resection that has the possibility to give these results for 0.7%, more than 500 patients. And it is, once it is repeated elsewhere, it is the same. So it is safe. There is also something new to investigate that should not be investigated by me. In example, I told you, and if you are curious, you can show, if you leave the pedicle and the in and the outflow, and there is a few liver, it regrow a nice new liver. But if you amputate, it will not regrow. And this is an advantage, in example, that it is difficult to measure. So I am not pretending to prove that we are better. I am asking, pretending I cannot, that this should be an option classified. And I think that now there is room for that. That's all. ALPS and two-stage has had the same course. There was no randomized trial, and also ALPS.
There was one, but that's not. No, I'm not saying, I'm not trying to do a debate. What the message is like the FDA testing new device. We should forget to show superiority. What we need to show is that they are safe, they don't kill patients, and then there is so dependent of the expertise, etc., that we will not go further than that. So I think this is safety, feasibility, some long-term data, but you cannot compare it to the other ones. It's like, it's not testing drugs when you need to show superiority.
I know, Pierre.
It's testing a technology like the FDA does, and we need to test safety. And I think you've shown that.
I agree, but if I would have not done what all of you have done for the other techniques since 10 years, there could not be even the discussion, and someone would say, why you didn't compare? We compare, so we have the comparison. I know that is not definitive. There are a lot of bias, but we need also this aspect to get seated at the table in which, please, include R1 vascular surgery. That's all. Safety.
Okay, you are terribly convincing. Thank you. Okay, we are moving on. On the same theme, it will be difficult for you, René, to justify liver transplantation for colorectal metastasis after Guido. Is it? Okay.
Thank you. Thank you, Laurent. Thank you, John.
Button there, René.
Thank you. The chairman is very useful, you know. So, no, my talk would not be a general talk about liver transplantation for non-colorectal metastasis. It would be a talk, I would say, paying attention to some point that we as surgeons have considered a very easy way to go for the best treatment, meaning feasibility, technical aspect, and outcome. So in terms of technical aspect, feasibility means what type of allocation. And indeed, we are faced with such type of multinodular non-resectable bilobar liver metastasis, several lines of chemo, potential aggressiveness, mandatory tumor control. And because of organ shortage, of course, we will have, for cadaveric, a long waiting time in the waiting list. And so we need priority access to transplant. And for that, we have presently two models. The Norway model, which is very simple. You ask for a liver, and in 17 days, you have it. And all the other models of cadaveric liver transplantation, which are much less simple, mean waiting time usually 6 to 12 months, MELD score unfit for those patients, and we proposed that the time to liver transplantation should be less than 2 months. You will see what are the results to avoid tumor progression. And for that, I give you the first result of the randomized trial, TRANSMET, who compare chemotherapy with chemotherapy and transplantation. And the originality of such type of trial was that we have an independent validation committee to avoid such type of, I would say, compassionate indication, because we know that as surgeon, okay? And from 157 patients submitted by tumor board, specialized tumor board in France, Belgium, and Italy, we come to only 63 non-eligible, we come to 63 non-eligible patients, meaning that 40% of the patients were excluded, while referred by expert tumor transplant tumor board meeting. And this was because of the unresectability was questioned, 21% of the case, because of tumor progression, hepatic, extrahepatic, or hepatic and extrahepatic, because of more than 3 lines of chemo or chemo resistance, it was in the eligibility criteria, or for other cause. So the first point is that it's not so simple. The second point is that when eligible patients come, 60%, and were randomized, 47, we come to the fact that from these 37 patients randomized in the group of liver transplantation, only 38 were transplanted. And so 19% of the patients were not transplanted because hepatic progression before LT, extrahepatic progression, intraoperatic finding of extrahepatic location, detection of a prostate cancer on a pre-transplant checking. And so for that, the median time for liver transplantation was 50 days, which was not so bad, knowing that the objective was to transplant the majority of patients within 2 months from the last chemotherapy cycle. And from that come what type of donor. And when we see now the literature, the majority of donors are living donors. Here you have the US experience, where 56.5% of the donor used for liver transplantation in such type of indication were living donor, okay? And if we see, I would say, the experience of the Toronto group, and this is the combined experience of the US, see, from 91 evaluated patients, only 11% come to liver transplantation, even with a living donor. And if we compare this with the Toronto experience, also using living donor, the same proportion. Only 9% of the patients that were referred were finally transplanted. So living donor does not seem to be, I would say, something which solve all the problem. And of course, we imagine some technical refinement of the technique, and this was proposed by the Oslo group, which is very interesting, the rapid concept, which clearly consists of, in such type of patient, as you know, to make a left hepatectomy, letting in place the right liver with a lot of tumor, then transplanting a small left lobe coming from a living donor or a split liver cadaveric transplantation, cadaveric donor, and then after 15 days to transplant, I would say, to remove, after hypertrophy of the left liver, to remove the right liver. This has been done in this, I would say, combined analysis, 23 cases, with a low donor morbidity, 4%. Early postoperative mortality was not so nil. It was 4.3%. And the conclusion was that such type of technique make that, in fact, we can consider this as safe. Now, coming to the risk of the procedure. As liver surgeon, experienced liver surgeon, we said initially, in theory, such type of indication is less risky. No cirrhosis, normal liver function, no portal hypertension. But in reality, it's challenging because we have CASH, liver damage by chemo, previous hepatectomy, history of prolonged chemotherapy. And in fact, when we come, I would say, to our randomized study, the first result shows that 3 patients were retransplanted, of whom 1 died. of multiple organ failure. And when we compare this to the literature, what we see is that from to date, all the reports show that the mortality is not nil, that the clavien d'Indo more than 3B complication is around 40%, and that a risk of retransplantation, of course, exists. Now, coming to the outcome, the same, I would say, line of idea. We are all convinced that transplantation is the best treatment, should give fantastic result, and so on. This was the old result of the European Liver Transplant Registry, who make it as a contraindication. Okay, this has changed, and the group of Oslo has published 60%, as you know, 5 years survival, confirmed by a Compagnons study made with Christian Toso and 4 of the Center of the Compagnons, showing that disease-free survival and overall survival at long term is possible, okay? But we are speaking about overall survival. If we come back to the 60% overall survival of the Oslo group in the initial report, we should have in mind that 19 out of the 21 patients transplanted recurred. And so they evidence something which is, in my view, very important, that the tumor recurrence after liver transplantation concern 2 different entities. One is pulmonary recurrence, which is an indolent pattern with a 72% 5-year survival, and hepatic recurrence, which is much more severe with no survival at all at 2 years after recurrence. And if we come now to more, I would say, refined selection of the patient, which is the SECA2 experience of the Oslo group, they were transplanting patients in tumor progression, which is for us a contraindication, and indeed now they are exigent with at least 10% response on RECIST criteria, with a time from diagnosis to LT more than 1 year. Even for that, they come to excellent results, 84% overall survival, but see what is the disease-free survival, less than 40%, meaning that it should be kept in mind the fact that recurrence is a frequent event after liver transplantation. So, to conclude very quickly, on feasibility, as a non-resectable colorectal liver metastasis represent an aggressive disease, feasibility represents the first technical limit for such type of indication, owing to the scarcity of organ, and to avoid such too long waiting time and tumoral progression, we have either choice of access priority to whole cadaveric liver, or with the alternative of living donor or rapid technique. For eligibility now, beyond the selection of specialized tumor board, 40% of patients might be excluded by an independent validation committee, meaning that a lot of compassionate indication may be done. Once selected now, almost 1 of 5 patients could not succeed to be transplanted because of tumor progression on the waiting list, despite, in our study, despite a prioritization of organ access for such type of indication. And the feasibility does not seem to be highly facilitated by living donor, as it's shown by the Canadian and the US experience. For risk and outcome, risk is not nil. It includes a clavien d'Indo more than 3 complication rate around 40%, 3 months mortality between 2 to 4%. 5-year survival is very good in hyper-selected unresectable patient, but recurrence remain a challenge, indolent for pulmonary, but with a poor outcome for liver and the other side, leading now to consider probably 10-year rather than 5-year survival, and disease-free survival also compared to overall survival for the long term, and still refinement in the selection process are needed. So the promising results of retrospective study still need to be validated on an intention to treat, considering the impact of organ shortage, to definitely validate the indication of transplantation for unresectable patients. Thank you.
We call Carlos Posito as discussant, please.
Professor Adam, dear Chairman, thanks for the excellent and interesting presentation. I'm here to discuss these results because also here in Italy we are running a trial on colorectal liver metastasis with Professor Mazzaferro, and we actually enrolled 22 patients. We transplanted 22 patients over 44, and we have 7 on waiting list. And I wanted to underline that also in our cases, as in yours, we experienced the same, that is that was not reported by the Oslo series, and that is feasibility of liver transplant is lower than expected in terms of eligibility, and that there is a dropout unexpectedly high. We also had 5 dropouts on waiting list or at laparotomy, which is a dramatic occurrence and something that was unexpected. And also, sometimes we found 2 patients with nodal positivity at laparotomy, which is another thing that is unexpected. My question is, probably we did not understand everything about selection criteria. And this occurred also with neuroendocrine liver metastasis. It is more difficult than for primary liver tumors to understand the predictive factors for recurrence and for dropout. And I wanted to ask you a comment on the possibility that probably the super selection of the Oslo criteria was also given by a very long time from diagnosis to transplant that actually, at least in Italy, we did not respect. We had 9 months from diagnosis to transplant, and this is probably one of the factors impacting on postoperative outcomes and on dropouts. But this is a reflection that I wanted to share with you. Thank you.
Thank you. Interesting comment. Indeed, the interval between, I would say, the colon resection and the transplantation is a very important criteria in the Oslo group. However, in our experience, the majority of patients have synchronous metastasis. And the vast majority of patients have received the liver first, I would say, approach. I mean, we have considered the liver initially because some of these patients have been resected before transplantation. And in such a way that to consider such type of interval for us is no more, I would say, selection criteria. Other criteria may be important, for example, the right liver, I would say the mutation of RAS. We exclude the patient with RAF mutation, but not patient with RAS mutation. It could be that in the near future we will go again still with a more refined indication, but in my view the delay is probably not adapted at least to the patient we have transplanted in the randomized study.
I have a question. In fact, you finish talking about the refinement of the selection criteria. In fact, I guess we are doing the same mistake than before. We are transplanting patient unresectable and very ill patients. So do you think that transplantation would be much better for patients, you know, those patients with a lot of metastasis? I'm sorry, Guido, but a lot of papers said that when there are more than 10 metastases, the recurrence rate in the liver is more than 80%. So they recur in the liver. So should we just perhaps study those patients who recur once, twice in the liver, but resectable, and they're finished to be out of the liver and it's finished? So do you think that the future is not to select chemotherapy, but select patients less ill than now?
Very, very good question. And I totally agree on, I would say, the rationale for that. And my view is that if you see all the transplant oncology, and I have made this statement yesterday, what we see is that the less, I would say, is the tumor load, the best are the result, and the best is the chance of cure. Milan criteria, cholangiocarcinoma, class skin tumor have shown what? That we should transplant patients with a tumor load which is lower. Now, for colorectal liver metastasis, it's a different problem. It's a two-stage way. The first stage is to convince the medical community, gastroenterologists, hepatologists, but mainly oncologists, that there is a rationale to propose liver transplantation for patients usually treated by chemotherapy, and to show that unquestionably the results are much better with liver transplantation combined with chemotherapy. But in a second stage, I think it will be interesting to compare what you propose, to compare marginally resectable patients in which Guido is doing such type of technique. We are using ALT, we are doing complex two-stage hepatectomy with, finally, we should recognize a high risk of recurrence. Probably this patient, marginally resectable, could be a still much better indication to liver transplantation. But today, in my view, it's too soon. But
okay, thank you. Oscar, you want to comment after?
Thank you, René. You're always updating us about this subject. A few questions. The first one, do you have some chemotherapy, post-transplant chemotherapy protocol for all this TransMed study? This is the first one. The second one is, did you find some different pattern of recurrence in patients who had, for example, rejection and needed boost boosters of steroids, or the different complications? Or I don't know if you have studied this issue.
Mm-hmm. So indeed, we recommend to all the team to do post-operative chemotherapy. And around 68% of the patients receive chemotherapy. It's not, by definition, a fixed protocol, because the medical oncologists of each center are doing the same chemotherapies that were working before transplantation, and they were doing the same in the post-transplant. And it could be very different from one patient to the other. Now, to have result about that, we have no result at all, because we still, the database is not freezed to make the total analysis of the data. And so, with regard to the complication, we have presently no data about the difference between those patients resected with before transplantation, not resected before transplantation. This was your question, or it was about immunosuppression?
About rejection after transplant. Rejection.
No, no. Frankly, we have not been faced with a severe acute rejection in such type of patient, and we use tacrolimus, steroid, and mycophenolate mofetil, and within 2 months we try to change mycophenolate mofetil to everolimus.
Okay, we have the two Eduardos.
Yeah.
The first one.
The oldest one first. I don't know if my English is enough good to put the provocation I have there. First thing, we don't need nobody to send us that kind of patients. We don't need to convince nobody. That patients belong to us, liver surgeons who have already treated that kind of patient. So I don't need that any oncologist send me, Eduardo, our center, do you think that patient with metastasis to transplantation? No, no. We don't. The patient is already with us. Because, and the second thing, I don't need your study to decide what kind of patients I need to transplant for liver metastasis. If I tell you the history of our first that could be arrested in Argentina, I tell you, the patient was a patient of us. We have treated 8 years before the first liver resection for liver metastasis. A second recidive 3 years after, something like that, only on the liver. And the third one, on the liver only after 8 years. Only on the liver, a patient with 44 or 45-year-old. I don't need any study, randomized study put that decision was obvious for us after discussing 15,000 patients in our center, 15,000 patients in our center. How can I refuse an obvious indication? Of course, that lady could be transplanted, and what will be was unbelievable not to give her the chance to have a fourth resection. And the fourth resection was not a partial resection, was a total resection. And we did a total resection with conviction. And the patient is alive 20 years after. So I don't need your study to decide what some kind of patients that we need. And that patients, and you don't need to convince the community, the gastroenterologists, the oncologists, you need to convince them to send us the metastases to partial resections. It's a very good thing. After that, we begin to take care of that kind of patients. Obviously, you have, after to do 2,050 liver resections, are not supposed to do an individual choice for some kind of patients. So thank you very much for attention.
Eduardo, so I agree and disagree with you. I agree, and I think if we make a quick survey, 100% of all the members in the audience are convinced. This is the point. I agree with you that I don't need to be convinced. I'm convinced. The only problem is that we are academic surgeons. And one of our tasks is not to cure only our patient, is also to convince, I would say, the other surgeon, the other specialty, about the rationale of doing what we are doing. So this is my view. And for that, I remember you, for example, and you have the memory of porta-caval shunt. You remember the history of porta-caval shunt. Everybody was totally convinced on the fact that a cirrhotic patient with bleeding who has a porta-caval shunt with no more bleeding, it was evident that we improve the survival of this patient. 4 randomized studies come between the 70s and the 80s who show no benefit in survival. And it was the death of porta-caval shunt. I'm not saying that because I'm convinced that it will not be the case of liver transplantation, but sometimes we are convinced of something that needs to be evidence-based confirmed.
I agree also.
Okay.
But can I just make a very quick point to add to what René said? We need to convince one other group, and that is the medical authorities. Only with data like this can we convince, for example, in the UK, to allow colorectal mets to be an indication for transplantation.
Don't react so strong against. Was a provocation? I agree with you also.
No, it's not a provocation, but we need that data. So, other Eduardo.
Yes.
Of course, fortunately, we are among surgeons. Okay, Eduardo.
Is regarding chemotherapy, and why not to? You said that maybe you need a post-transplant chemotherapy. Now that we can have a Signatera and we can dosage DNA in blood, why not to be more rational? Because maybe when you perform the liver transplant, the patient is the best R0. And maybe if the Signatera is low, and now is more cheap than before to dosage the DNA. Why not to be more rational to apply the chemotherapy? That's my question.
No, it's a good question. And now we have tools that we haven't at the initial part of this randomized study, because we begin in 7 years ago. At that time, the ctDNA, the circulating tumor cell, was not so a useful tool as it is recognized today. But I think it's an interesting way. No ctDNA negative and so on, no chemotherapy. ctDNA positive, at that time, a good indication of chemotherapy in an adjuvant setting.
Interesting. Hugo.
So, first of all, I also share this view that biomarkers like Signatera are going to be very important to select those patients. 2 quick things. First of all, at the point where you accept that you are starting to do liver transplantation for colorectal metastasis, we end up seeing that we have much less candidates than those that we first anticipated. So I think the number of candidates is actually much lower than we thought. I don't know if you have the same impression or not, but with such a large pool of patients, how come we have such few candidates? And the first and the second thing is the place of living donor. What do you think?
I respond to you to the first question, which is very close to that of Eduardo Barroso. We have to convince the medical oncologists that this indication exists, because I have very good friends, medical oncologists, who said to me, I don't believe in liver transplantation. How to convince them? And they are very authority in the field of digestive oncology. They said to me, René, I don't believe in liver transplantation. No, see the result. I don't believe. So only factually we can convince them, and having more patients recruited. And you will see that in the near future, if we can convince them, the thing will change. And the second question was?
How do you see living donor liver transplantation in this setting?
I think living donor will come in a second stage, I would say, because today in France, at least in France, it's impossible to use living donor for a non-validated indication. Once the indication will be validated, no problem for doing living donor. And it's a good indication for me.
Gordon?
Things have been said. I think a group that will be extremely difficult to convince without this kind of data is the hepatologist community.
It's?
The hepatologist community, because it's not really only the medical oncologists who hold the key to this, but the hepatologists have very strong feelings about the allocation of livers to patients that they don't really always consider to have, entre guillemets, liver disease.
Sure.
So it's a very, we've encountered this dynamic and this almost wall. Why this is, again, very important to have this kind of information to convince the community. I think the transplant hepatologists need considerable education.
It's a very important issue, Lee. A very important issue when I present this to Agence de Biomédecine, which is our Society of Organ Sharing. In fact, many hepatologists said, oh, if you put colorectal metastatic disease in the indication, you will take all the livers, we disagree, and so on. Today, factually, these represent no more than 1.5% of transplantation done in the European country concerned by this indication.
This is why it's so important to disseminate this information to these communities, I think.
Sure. Mm-hmm.
Yes, this is a major point of this study, and I have to congratulate René, because I remember they said, you opened the Pandora box. There are too many patients, and it is in the fact that you form that committee to examine each patient. It was really rigorous, and I think that's the way to convince that we are responsible for this indication. Christophe, another comment question.
Thank you very much. Great talk and inspiring, like usual. Regarding our discussion about the medical oncologist and the hepatologist, transplant hepatologist, did you elaborate or have any idea how to survey the patients after liver transplantation, no matter whether they receive chemotherapy or no? Are there any special biomarkers, CEA, ctDNA, whatever? Do you have any idea or any about it?
Thank you for your question. We have not used this tool up to now, but all the patients are followed not only by the transplant surgeon, but the medical oncologist in charge of the patient initially, and also the hepatologist or the gastroenterologist in charge of the patient initially. So this is a multidisciplinary follow-up of the patient also.
Given that about 80% of those patients have a recurrence, I think that we have to be very, very precise to build a kind of a surveillance, the protocol.
But this was very well protocoled. Every 3 months, the patient has a CT scan, MRI every 6 months, PET-CT every 6 months, tumor markers every month. So this was very well protocoled in the trial.
Thank you.
Professor Bismuth?
It's time to close, I think, the discussion. I have only one question. If we consider the total population of patients with colorectal liver metastases, how many do you think are alive after 5 years? The total population? Less than 20%? 15?
It could be for the global population, it should be less than 5%, because we know the resected one is 25% at 10 years alive. If we mix this with all the non-resected patients, it will lower probably around 5%, no more.
Do you think colorectal liver metastasis is a surgical disease?
I will not respond to this question.
Thank you. Now we are really depressed. Okay, thank you, René. Professor Aldegrete, it's my pleasure to introduce you to speak about the place of minimal access surgery in surgery of colorectal liver metastasis.
Thank you. Thank you very much for Guido for your invitation. It's a great honor to be in front of this community. So I have to answer which is the role of minimal invasive surgery in colorectal liver metastasis. So the first answer is that laparoscopic is superior to open liver surgery for colorectal mets. This is a paper we published, I think, 5 years ago, almost 900 resection, splitted by approach, and then divided by propensity score 1 to 4, and we find advantages of laparoscopic approach in terms of blood loss, morbidity, transfusions, and postoperative stay. And if we go higher in the pyramid of evidence, we find a prospective randomized trial from Oslo that is basically saying the same. There are advantages in terms of lower postoperative complications and a lower hospital stay. And what is important is that in this study, we also can see a lower inflammatory profile in those patients operated by laparoscopy. And finally, at the top of the evidence pyramid, we find also a meta-analysis that was published last year that is giving the same results. So there is a benefit in terms of postoperative course, complications, and in this meta-analysis, there is also, in a way, suggested a better oncological outcome. So that's why I think that minimal invasive activity is mandatory at the present time in any center which is working on colorectal mets and in general in liver surgery. And indeed, this is a survey published 2 years ago that is telling us that in high volume centers, almost 30% of resections are done by laparoscopy. So the true question is not if laparoscopy is superior to open surgery in colorectal mets, but the true question is if minimal invasive surgery is feasible for all patients with colorectal mets. And if you look at this point of view, well, we see definitely a different picture. These are the data from the IGO-MILS registry that is presently data from almost 8,000 patients. And you can see here that only 40% of the patients with colorectal mets are actually operated by minimal invasive surgery. And if we look at our experience, we are just above 2,000 minimal invasive resections, including laparoscopic and robotic resections. But if you look at this part that is recording the activity of 2022, as you can see, there is a wide space for open surgery. three types of techniques: open, robotic, and laparoscopics, and basically each of them is getting 1/3 of the activity. And going into that, again, the activity of the last year, 341 resections. And if we look by diagnosis, you can see that while more than 85% of resections are done for cholangiocarcinoma and for hepatocellular carcinoma, only 50% of resections are done by minimal invasive approach for colorectal mets. These are the features of the series. And indeed, in spite of the fact that in our center, all patients are candidate at first to minimal invasive approach, we have some contraindications to meals. And as you can see here, some of them are specifically applicable to colorectal mets. So multiple and complex resections, parenchyma-sparing resections. Obviously, we are talking about colorectal mets, so we are on principle talking about parenchyma-sparing resections, lesion infiltrating major vessels or vena cava, and so on. These are some of the pictures of the last year that is telling you that even if minimal invasive surgery is superior, we actually have difficulties to apply this technique to many patients with the colorectal liver metastasis. Here are some pictures of those cases operated last year, and here some need of complex operation with grafting or prosthesis. The major factor that is influencing the possibility of minimal invasive approach for colorectal mets is for sure the number of the lesions. This is a paper a couple of years ago actually, that was focused on synchronous resections, 3 series. And when we go above 4 lesions, it's maybe already a problem to enroll the patient to the minimally invasive approach. And indeed, in this paper, that was asking to many surgeons their point of view in terms of approach to clinical cases, what we see is that the more complex is the case, the more all surgeons agree with open approach. So we need, in a way, to find a balance between the feasibility on one side and the advantage on the other side that we have recognized in many papers comparing open and laparoscopic. In spite of the fact that apparently the high is the difficulty, the larger is the advantage if the patient is operated by laparoscopy. This is a paper we published last year showing basically this concept that in low complexity cases there is not a large advantage, but in the intermediate, in the high difficulty patients, we get more advantage if we are able to operate the patient by laparoscopy. On the other side, the real problem is that we are often not able to operate this patient by laparoscopy, or at least we need a prolonged time when compared to open surgery. And these papers are telling us that operative time is not something that we cannot forget. When we go to a very long operation, we may give to the patient a bad impact just because of the duration of surgery. And length of surgery is actually a consequence of number of lesion, size of lesion, location of lesion, relationship with vessels, the number of transection surface. This is another important point. Obviously, it's not just the number of the lesion, but it's also the type of resection that is needed. So probably we need, and I don't have an answer about that, we need to define some specific models that are able to define where is the limit of the benefit of minimal invasive surgery when applied to colorectal mets. Basically putting together number of lesion, size of lesion, the depth of lesion, the extent of resection areas on one side, and on the other side, the advantages that we have already recognized on minimal invasive surgery, including a low inflammatory profile, lower blood loss, and lower morbidity. As I said, I don't have an answer. This is the way that we have to work on. Probably we need models by applying deep learning, machine learning, or artificial intelligence, because it's so complex to put together all this data that it's very hard to draw an answer without a specific model. I don't have still the final answer, but it's going to come. We are working with some engineers to define a model based on the artificial intelligence, specifically to define when we shouldn't go for a minimal invasive approach in colorectal liver metastasis. We are working on the data of the EGOMIS registry. We know at this point that topography, number of lesion, and size of lesion are definitely important, but as I said, the answer is not here yet, but it's going to come soon. So my conclusions are that even for colorectal liver metastasis, minimal invasive approach is gaining the momentum with a clinical outcome that are favorable and results that have been documented by large cohort studies, randomized control trial, and even a meta-analysis. Oncological results are adequate, if not superior, if we look at that meta-analysis. But two are the most important point. First, any liver transplant, any liver resection program need to work with minimal invasive resection also in colorectal liver metastasis. This is one point. But the other point is that minimal invasive liver surgery is not the dominant approach for colorectal liver metastasis when compared to ACC or cholangiocarcinoma. Probably the number of the lesion is the easiest factor affecting the indication to MILS, but we need more sophisticated studies to put together on one side the advantages of the MILS and on the other side many factors that can affect negatively the outcome. Thank you.
Yeah, so Guillermo for the discussant, please. Yeah.
Thank you for your nice presentations. So you know that the minimal invasive surgical approach to liver sections has been increasingly adopted to treat the colorectal liver metastasis. So you know that the laparoscopic liver approach to treat the colorectal liver metastasis is associated with less intraoperative blood loss and short hospital stay when you compare with open approach. So the operative time is the same in our days. When you compare the robotic liver approach, you know that in some cases, in some series, the rate of improved R0 margins, so it's good, but you know that the surgical minimum approach can reduce the time from the surgery to the initiations of the chemotherapy. But there are papers say in other hands, you know that some series are some papers show that there is no significant difference 5 years overall on disease-free survival between the 3 laparoscopic, robotic, or open approach. So I think the more important is the surgeon experience. The more important is not only the surgeon experience, is the surgeon experience in that sense. So the experience of the department or the surgical department. So this is factor, in my opinion, should be part of that decisions. Thank you. So a comment for you.
We'll go to questions. Hugo.
Look, thank you very much for this very nice presentation. I want, first of all, to congratulate you for your robotic program that I see that is growing very fast. You have almost 300 resections already. And I wanted to ask you a comment on this, because for us, for example, one of the main groups where we select less patients for minimal invasive approach is precisely colorectal mets. And it's not only because of the number. Of course, it's much more cumbersome to treat 10 or 12 or 15 metastases by minimally invasive approach, but also because sometimes it is very difficult to find small metastases because you don't have the tactic sensation, and also because the performance of intraoperative ultrasound is less optimal. What do you think of this?
Yes, probably. When I say that minimal invasive is not feasible in half of the patient with colorectal mass, I put together a lot of things, including what you said. I don't have an idea if laparoscopy or robotic approach can really change the situation. For example, by ultrasound, I think the possibility to work with the probe with the robot is better than laparoscopy. Maybe with the robot it's possible to do more complex resections, but I don't have a feeling about that. For sure, what I think and I want to stress is that there is no conflict between a minimal invasive approach and open approach for colorectal mets. It's just that we need to understand when the benefit of minimal invasive approach that is clear in a group of patients is lost by other factors. And so when we shouldn't push with the minimal invasive approach, losing advantages for the patient. And so this is where we need to work on.
And another expression is, I think that to remove more than 10 metastases is definitely not a minimal invasive surgery, whatever the approach.
Well, you know, it depends on the postoperative outcome. If you have a better postoperative outcomes in terms of morbidity, blood losses, hospital stay, functional recovery, that's a minimal.
Yes,
I don't know if you understand my point.
Yes, of course. Minimal invasive is a good outcome.
Okay.
It's not the approach, it's the good outcome.
Exactly.
You can say it's minimal after surgery and not during surgery. That's what I mean. And honestly, when you have more than 10 metastases, you need something, well, you'll have some morbidity. So whatever the approach, it will be minimal, this type of surgery, 10 metastases.
Yeah, I totally agree with you. That's why, as you saw, this is a specific contraindication in our center. We don't even try. And that's why I think we should put together data and efforts to understand and in a way to standardize when the advantage is lost.
Exactly.
This is what we don't know. This is what we don't know.
Okay, we'll go to Gina's. Can I just quickly ask you a question first? Are you finding with the development of the techniques and experience and based on the outcomes in terms of shorter length of stay and less blood loss, at your multidisciplinary tumor meetings, are you thinking of minimally invasive as the default approach and then find a reason not to do minimally invasive?
It's certain that we define at the tumor board the type of approach. We don't like to put that issue in the discussion. So we do not operate a patient because the patient can be operated by minimal invasive approach. The decision about the approach is then, in a way, a specific surgical decision based on what we feel can be the feasibility, we are talking about colorectal mets, and the outcome.
Gina?
Yeah. How do you integrate the management of colorectal liver mets? Meaning, when you make your decision in your tumor boarding, I understand that you will choose, of course, minimal invasive approach for that type of patient. Do you integrate also the concept of transplantation for colorectal liver met? Meaning, do you have a large view, or do you decide, I need to do only this approach? Or is it really, I'm treating the disease?
In our center, we don't have a liver transplant program, and that's why we have a specific convention with the liver transplant center. So the issue of a possible liver transplantation for colorectal mets is already discussed, and obviously the patient is then referred, if considered a potential candidate, then to the evaluation in our referral center.
And the last question, if you don't mind, and what is the rate for repeat hepatectomy in case of recurrence? How do you approach them?
Oh, we don't think a previous surgery is a contraindication to minimal invasive approach. You saw the contraindication. So out of there, the patient is considered for minimal invasive approach.
Thank you, Luca, very much. My question is regarding imaging with a minimal approach. Is the quality, because we have developed a robot to operate that is very expensive, but we have not progressed many in the fusion of imaging, in the intraoperative fusion of imaging. That I think it can be supported by the new technology. What do you think about that? And the use of the common intraoperative ultrasound has the same sensibility that the use of in the open surgery?
I would be happy to have something for intraoperative navigation. I have to tell you that one of the problems with minimal invasive surgery is that there are areas of the liver where if you are not really experienced, you may lose your right direction. Maybe in posterior segments, maybe deep in the posterior part of the segment 8. Sometimes you need your own experience to understand how to draw the transaction plan. And this is not good for the community. Obviously, we should have instruments that can avoid a surgeon to become experienced before understanding how to do things. So I totally agree with you. We need those tools.
Thank you, Professor. I have a question about combined approaches with intraoperative thermoablation. Does this kind of strategy influences your choice in minimal invasive or open access?
As I said before, at the tumor board, we decide how to manage the patient, including if in multiple colorectal mets, some patients are good candidates to combine resections and ablation. And then we decide about the approach. So again, we don't take the patient to the minimal invasive approach to avoid some resection and do some ablation, even if the patient is not a perfect candidate to ablation. I don't know if I'm clear.
No questions. Thank you, Professor Andriani and Guilherme. Thank you very much. I understand Dr. Vorti has arrived, but it's a little bit late with the timing tomorrow. We're going to have his talk tomorrow. Good, so we'll go on then to Matteo Donadon from Italy. Thank you. And afterwards, Christian Toso will be the discussant. And the topic is the bench, research, and surgery for colorectal liver mets.
Good afternoon. Thank you, Mrs. Chairman and Mr. Chairman, and thank you for the invitation, Professor Torzilli. I'm honored to be here in front of such a great community of HPB surgeons. My topic will be about the bench surgery in colorectal liver mets. We know that colorectal cancer is one of the big killers. It ranks up to the third cause of cancer-related death. But we also know that since up to 70% of the patients develop colorectal liver mets, we know that there is an important effect of hepatectomy together with the system of chemo that allow us to say that we can reach approximately 50% of overall survival at 5 years. And this is a fact that is reported in the current guidelines. This slide shows the ESMO guidelines, the American guidelines, in which, as you probably know, in comparison with a few years ago, there is more and more space for hepatectomy, meaning that for sure hepatectomy for colorectal liver mets can be considered as one of the line of treatment. However, when, as a surgeon, sometimes we face some disillusion, in front of a patient that we decide to operate because of hepatectomy, because of colorectal liver mets. And for sure, I'm talking about the issue of mortality and the issue of recurrence. I will stay on recurrence, and the point is that we really need to focus on which are the main determinants of prognosis of our patient, because I agree when we talk with patients, because we are surgeons, on the sophisticated techniques to operate our patient, but the other face, of the medal is about if our surgery is associated or not with a good oncological outcome. This slide shows our series here from Humanitas, published last year, of about 900 patients discussed in almost 10 years in our weekly multidisciplinary team because of colorectal liver mets. Among these, 521 underwent surgery. If you look at the survival analysis and the multivariate analysis of the whole series, the factors that came out to be significant are almost the same we are used to read on papers, such as the lymph node status of the colorectal cancer, the KRAS status, the timing of metastasis, the size number, and of course, the level of CEA. So nothing really new. So the point to me is that probably we should make some efforts to try to don't think that prognostication is anymore an art, and we really need to have a personalized approach in reality. And so probably the way is to change the dogma, change the paradigm, and one of the way to me is to use really translational research. Everybody here knows what is translational research. I just want to point out that the famous slogan is from bed to bench and back, and not vice versa, which means that this type of research should run by clinicians, by us as surgeons, because we see the disease, we touch the disease, we know the patient, which is not the same for basic scientists. So which is the rationale? The rationale is the risk stratification, patient selection, improving communication with family and the patient, gathering data to guide the therapy decision-making, and hopefully limit some of the disillusion that sometimes we face in our patient. So the point is that we need to consider our operating room as a lab, because translational research is just a method to answer a clinical question. It's a way to integrate the basic knowledge to address a clinical problem. And to me, there is a strong difference, between a human and mice. So mice is a good model, but we are not mice. So probably we need to spend much time to work on the real human disease. So the little story I would like to tell you is about my experience that I did here in Humanitas, because I had the opportunity to talk with some of probably worldwide famous immunologists that work here. And so the idea was to try to approach liver surgery through the immune system, to study the host biology more than the tumor biology, so to shift the paradigm of prognostic factors from tumor-centered to host immune-centered factors. And what we did was to start a systematic collection of samples of any patient we operated, so not only colorectal liver mets, but the main 3 diseases that we operate. So we collected tumor and peritumoral samples together with normal tissue. We apply a specific new original technique to isolate cells, meaning tumor cells, normal cells, and also any cells in the liver, together, of course, with the peripheral blood. And we focused our attention on the cancer-liver interface, so the space between the normal liver and the mets, the metastasis, or anyway the cancer, to try to define some new mechanism behind the tumor growth, the tumor resistance. I like to quote this paper from Anand, published last year in Cancer Discovery. It's an update of all the tumor features that characterize the tumor cells and the tumor growth in general. And it's interesting to note that each of these areas represent a specific research areas that in which we should spend time to try to understand, many problems we face in our patient. So I like to go a little bit in details, and I will give you some quick shots of our works just to make you aware of what we did so far. So this is one of the first papers we published after a meeting of the SSAT, and here we look at the intratumoral compartment, and we look at the rate, the frequency of NK cell and T cells inside of colorectal liver metastasis, and we were able to define 2 different groups of patients. Of first cohort of patients with a very high frequency of these cells, with a very, very good overall survival, compared with the greater proportion of patients with low frequency of this tumor, meaning that the intratumoral compartment is a good space in which we have to spend time, and in this case, NK and T cell may define the prognosis. Another really interesting research line we have open here, which has been awarded last year on a national grant, is about the relationship between RAS mutation and immune system. This was a preliminary paper published a few years ago in which we look at the difference in the frequency of tumor-associated neutrophils in RAS-mutated versus RAS-wild tumors, and we were able to find that the RAS-mutated patient had higher infiltration of neutrophil. It's interesting to tell you that this observation originally was because we realized during the operation that there was a difference, a physical difference of the colorectal metastasis, mutated versus non-mutated, meaning that the mutated appears to be macroscopical inflamed, and this was what we found. And the main research is ongoing, but for sure there is a strong relation with the RAS biology and also with the prognosis. Another research line is this one, which is still open. It's about tumor-associated macrophages, and we define with sophisticated analysis at least a couple of different subtypes of tumor-associated macrophages associated with a strong prognostic significance that could be used even on a routine basis to define much better the prognosis of our patient in comparison to other factors. And it's interesting to say that the same observation has been recently validated on an external cohort of a patient operated here in Milan in another institute. And so the thing is real. It's not just here in Rozzano. It's everywhere. And Another research line, it's about unconventional T cells. In these two papers, we look at gamma delta cells, which are two new, relatively new cytotoxic cells. And in the first paper, we found, not really surprisingly being surgeon, that chemotherapy in some patients can give an impairment of T cells, in particular of these unconventional T cells, which means that tumor can grow paradoxically. And more recently, we defined a specific ligand for a subtype of gamma delta cells, which open a completely different scenario, because as you probably know, from ligand we go to look for checkpoints, and from checkpoints we can go to target therapy. So this is a very important line. And finally, the last paper I would like to quote is the most recent published on a sophisticated argument, which is the cellular senescence, the so-called zombie cells, which are specific cells that can be found in any solid tumor, not really new so far. We were able to define at least two groups of these zombie cells thanks to spatial transcriptomics associated with a prognostic significance. And again, this is an area that can be further investigated in the light of applied target therapy. So I'm going to my conclusion. Again, this is the slide I showed before. In green, you can see the 7 areas in which we are working on out of the 14 proposed by Anand last year. And in conclusion, why benchmark research in colorectal liver metastasis surgery? Of course, because patient selection dictates outcome. We need to improve the knowledge on tumor and host biology, and we as a surgeon are in a unique position for this job by considering that OR is our lab. Of course, I'm not alone in doing this important work. Here there is a multidisciplinary team also for the lab, which include some surgeon, hepatologist, researcher, pathologist, and more importantly, the group members of people that really do the job. Thank you very much. Thanks for the invitation.
Now Christian Toso for discussing.
So thank you and congratulations for the talk, but also for all the work by yourself and the group. I was impressed by all the data, but at the beginning you stated that in fact it's important to look at the metastasis, but also at the underlying liver and its immune status. But then, if I understand well, most of the results you have shown were looking at the invasion inside the tumor, inside the mets by immune cells. So my first question is there a difference between the immune cells inside the mets and in the neighboring liver tissue? So that's going to be my first question. My second question is, if I understand well, you have mainly looked at patients that were undergoing surgery and you were gathering samples at this specific time point. So did you see any impact between patients that had received chemotherapy before and those who didn't? And do you have any data, assessing how patients and the immune status behaves over time? And maybe my last question, and maybe most important, how do you translate all of that in clinical practice? Because of course now we have a snapshot on how it is at the time of surgery, but what I would wish to have is something prior to going for surgery, and maybe selecting patients that should not go surgery, maybe will do better with chemotherapy. Is there a way to gather all these data just based on a biopsy? Sorry for all these questions.
Thank you very much for the questions. For the first one, in most of the cases, these data came from the invasive margin, so the space between the normal liver and the tumor. I show a couple of papers in which look at the intratumoral compartment, which is, by the way, the most difficult compartment because usually not many immune cells can be found inside. But to me, we should look at the normal liver, meaning the distant part, even far away from the tumor, the invasive margin and the tumor, because to try to understand, all the story. The second question was about, was about...
with and without chemo.
Yeah, sorry. So, of course, we got this data only from those patients that we operated. So we miss the denominator of the large proportion of patients. We don't know what happened in those patients that maybe Professor Adam or Professor Sposito transplant or you transplant, or patient who only does chemotherapy. We built our collection on this series, so we should open the, start collection from patients treated only by medical oncologists.
But I'm guessing that some received chemo before surgery and some other didn't.
Yeah. Speaking about the colorectal liver mets, most of the patients got chemo. So even if we did in each paper a multivariate analysis that mainly reported no influence of chemotherapy, meaning that the result is independent by the use of chemotherapy, it's true to say that most of the patients had chemotherapy. So this point should be further clarified.
And the practical?
The practical is something we are working on. Of course, it's difficult. We started a few years ago to work on some engineers to build an AI tool to help the pathologist, because in the real world there is a pathologist that read the slide. He or she, they don't have too much time to look for these small cells. So we built a research line to have a specific tool. The project is still open. We will see.
Thank you. Any question? Yes, please.
Nice talk. So I ask you, because in Coimbra, in our department, we studied desmoplastic metastasis and no desmoplastic metastasis. And we showed that in the decreased number of all monocyte cells in the patients with desmoplastic metastasis, so with increased survival of these patients. What do you think about that?
Yes, I know. It's an important observation. Thank you for the question. Of course, the type of tumor growth, the specific type of tumor growth has been reported in literature also by you, and it's when we talk about basic science, translational research, each area it's important to cover each area of this research. Personally, I don't have experience on that research, but it's an important point.
Thank you. Any question? Yes, I have a question, like a pragmatic question. No, just you study intratumoral NK cells, and you see that it's a great difference in survival. RAS mutation also, spindle cells also, but all that you just study this factor. But there is a lot of other factors: clinical, chemotherapy, size, all that. So I just follow the question: could it be useful for with a biopsy, studying NK cell or spindle cell, anything? Because I don't. I'm not convinced about the real impact on survival of these solitary differences.
I have to say that in all of this research, we show that these data were confirmed by multivariate analysis, in which we put all the standard traditional clinical pathological factors that we as a clinician use to define the outcome, meaning that when NK cell came out to be significant, that was at multivariate analysis. Of course, the Kaplan-Meier was just a picture, but behind that there is a multivariate analysis. And this is the difference, because we as a clinician, we know that when we see a patient, we see a CAT scan with 5 colorectal liver mets, we don't see NK cell, of course. But behind the size, the number, the CA level, which we use, which probably nowadays are too grossy. You need something more in details to define really the prognosis of our patient. With the biopsy, yes, sometimes the problem is more technically from the research side rather than practical, because for some research, the amount of tissue you get with biopsy, it's
not enough.
Yeah, not enough.
Okay.
Okay, thanks. Thank you very much. We'll call on Christophe now, and Christophe's going to speak to us with an update on surgical management of breast cancer liver mets.
Thank you. Dear Compagnons, dear colleagues, first of all, I would like to thank very much Professor Bismuth, Professor Ugo Marquez Pinto, and Guido Torzilli for the possibility to present this paper. We have switched the topic, the most important topic of our first day, like colorectal liver metastasis, to another important issue, the liver metastasis from the breast cancer. As you know, so far, it's absolute contraindication to the liver transplantation. However, as far as I remember, the discutant of this paper, Professor Ettore, with his group, already published the first pilot study about this transplantation. It doesn't work. Sorry. Maybe I take this one. So, the breast cancer is, at the moment, the second most commonly diagnosed and second leading cause of death of cancer in women. To an example, about 300,000 new cases of the invasive breast cancer occurs, and the death toll is really very high, even in the best developed health system countries. 6 to 10% of the patients have the distant metastasis at the time of diagnosis, and only 27 of them reach 25-year survival. The predominance of the metastasis are bones, lung, and liver. However, it's the poorest survival, the worst prognosis is for those with breast cancer liver metastasis. However, the recent international consensus guidelines for advanced breast cancer from 2018 present that resection is considered in selected patients. Quite recently published a paper in Journal of Translational Medicine showed that there are 5 important mechanisms involved in breast cancer liver metastasis. It is the intravasation from the primary breast cancer, then the circulation, margination in the liver, extravasation in the same organ, and colonization. Looking at the history, the first papers, the first informations regarding the surgery for breast cancer liver metastasis were published about 25 years ago. The first series were relatively small, with 50% patients without postoperative chemotherapy, with overall 5-year survival about 60%. The next paper, published 3 years later, the greater series of 52 patients with 3-year survival differing from 48 to 82%. However, those patients have about 4 years time from the breast cancer diagnosis to the liver metastasis development. The authors emphasize the importance of patient selection for hepatic resection for breast cancer liver metastasis. Looking at the recent studies investigating the clinical impact of metastasectomy for the breast cancer liver metastasis, the first impression is that the median survival is from 42 to more recent studies, even 97 months. Of course, these data are biased by the very selected patients. Quite new, I know the authors quoted that the variables associated with outcomes are mainly hepatic volume of the disease, the primary breast tumor hormone status, extent of liver resection, and long interval between primary diagnosis and liver metastasis. More recent study, prospective ones, proved the same rule about 57 months of survival up to 81 months in best group, that all varied based on the receptor status. So in conclusion of this review, we know that independent predictors of the poor survival for the poor overall survival are number and size of liver metastasis, the subtype of the tumor, the best HER2 enriched and estrogen and progesterone minus FGFR2+, the longest survival about 81 months, and the so-called triple basal-like minus the very short, not the passing 1.5 months. 5-year survival in surgery group reached 56% versus systemic therapy group 40%. Also, quite recently published paper, research in BMC cancer, showed that it was the analysis of 300,000 breast cancer patients from SEER and 1,700 patients from Chinese cancer registry. They showed and proved that the risk factors for developing metastasis are the young age of the patient, invasive ductal carcinoma, high pathological grade, triple negative subtype, already mentioned in the previous reviews, and human epidermal growth factor receptor positive. The longest median survival are for the human hormone receptor plus and HER2+ subtype versus triple negative subtypes. Here you see the examples of the overall survival for the group, and here are the examples showing the particular subtypes of the breast cancer, the worst with the worst survival for triple negative. Very nice paper from Italian center published in World Journal of Oncology, analyzed almost 4,000 patients with non-colorectal, non-neuroendocrine, and non-sarcoma cancers. And as you see, almost 1,000 of this group were the patients with metastatic breast cancer. The authors concluded that surgical approach to those patients is essentially based on two fundamental issues. One is that liver surgery and liver resection become safer due to improved surgical technique, better pre- and intraoperative managing, and parenchyma sparing policy. The second issue is the complementary role of the new and very effective, very potent systemic therapy combined with the surgery. They found the most important prognostic factors that primary site and histological subtype, surgical margin status, adjuvant treatment, presence of extrahepatic disease, and number of metastases. In conclusion, those patients with the metastatic breast cancer and genitourinary primary site obtained the major benefits. The size of metastasis should be less than 5 centimeters, and the appearance of hepatic lesion longer than a year after the primary. At the end, a snapshot of the results we have obtained in our department in Warsaw between 2017 and 2021. We have operated on 25 patients for this indication, relatively young, of median age of 53 years, with different number of the lesions from 1 to 12, very big discrepancy of the metastasis from 5 millimeters to 12 centimeters, obtaining different margins, and the survival median of more than a year, mean almost 2 years. The majority of the surgery for breast cancer metastasis were performed with the open approach, open surgery. 4 patients were operated on with the laparoscopic technique. The majority of the patients underwent anatomical resection. However, the 1/3 was with wedge resection. R0 was obtained in 87% of the patients. Here you see a few examples of the multiple metastasis and liver remnant after the surgery. The overall survival reached 50% after 5 years. In summary, the best candidates for resection of breast cancer liver metastasis are patients with limited tumor burden to the liver, with longer interval between a primary breast and liver metastasis diagnosis. The HER2 enriched breast cancer subtype responded to systemic therapy. Resection and ablation are warranted in carefully selected patients after discussion at the MDT meeting. Oligometastatic disease management should be driven by the predilection of the clinical team and patients' wishes. That's also important. And obviously, the randomized controlled trials are necessary to evaluate the most effective and evidence-based approach. Thank you very much for your attention.
Professor Ettore, yeah.
Compliment Christophe for this presentation, and you evocate my transplantation of the patient with breast metastasis. It was a patient, for the Compagnons, was a patient with only liver mets from breast cancer that was treated from 3 times for chemotherapy and radioembolization, and developed a real syndrome with ascites, and for this reason we transplant the patient for a year and a half. But the oncologists say it's not possible to transplant, it's too dangerous, but we transplant and the patient is really well, 5 years and a half. So I think that surgery and transplantation in selected case, you stratify very well the subgroup of the patient is a good indication. My question is, I don't say the time of stability of the disease before surgery. I think this is a really important point. We wait 6 months. And what's your opinion?
I think it is a very important issue. Of course, the longer the time between the primary, the better results. At our hospital, we have no breast cancer unit. That's the special places in the National Oncological Network. So the patients sent to us are already treated for a long time, at least a year or sometimes even more. So in case of stable breast cancer metastasis, in repeated imaging examinations, we qualify them to the surgery. So it's usually more than a year, sometimes 2, 3.
Just a question about non-colorectal breast cancer metastasis, but also other non-colorectal metastasis, because we have now, because of a new therapy, some indication quite disturbing, like oncologists saying that they control the disease outside the liver, sometime for breast cancer in the bones, but the metastasis in the liver does not respond. And they ask us to do something locally, although there is extra hepatic metastasis. Do you have this experience, and what do you do? Do you accept to do surgery in that condition?
Yes, in general, yes. Of course, we won't find the indication to the transplantation. But if those bone metastases are, let's say, dormant, and if they are ready to be to radiotherapy, of course we cooperate with the radiotherapist and we try to find the best way and the best timing for both procedures, radiotherapy for the metastasis in bones and for the surgery, unless it's not, let's say, heroic surgery.
Okay, because in your factors there is no extra hepatic disease. The absence
in this series, it ended 2 years ago. There are only the patients with only hepatic metastasis, but we tried to widen our indications and resign from very strict indications.
Okay, Pietro.
So thank you. We have a completely different approach, which is I really need the oncologist to tell me why it's helpful that we go and remove the metastasis. It could be dissociated response. It could be the only one. But it's rather than selecting a few positive factors, which are in fact the ones that are positive for breast cancer in general, so that I don't find very useful, is really a tailored indication driven by the oncologist telling, I need you to remove this because, and I have to be convinced for that. And I think that's the only way I can get out of the immensely evolving field that they have in their hands. And in fact, a randomized trial or survival curves will not, in fact, for me, help in selecting which patients are useful to go for surgery.
Pietro, I respect your point of view, absolutely, you are right.
It's yours also.
But those patients who are referred to the surgeons by the medical oncologist are the patients for them, if the breast cancer is stable, there are metastases in the liver, I think that it's a kind of salvage surgery for the patient. I think that's, I don't like to use the term compassionate because it has some academic or scientific principles or basis. But in general, if we are ready to uncomplicated future liver surgery, we should offer. That's my opinion.
I was saying the windows, in fact, for me, is not for those patients. It's for other patients that we find good chemotherapy. So say, if you operate on this, I can stop the chemotherapy for 2 years and just leave them on a very non-toxic maintenance treatment. These are the kind of patients, I think, that are good for resection,
Yes,
not the compassionate ones.
That's the evolving indications for non-colorectal, and not only breast cancer, but also other
I think that this is the story of the breast metastasis in the liver. This is from conventional to the future, because explain very well the conventional treatment of the colorectal, the history of the breast metastasis, but the future is changed, like Piero said, because the PET scan, many imaging difference, so they have a specific treatment, even extra hepatic disease.
Yeah, René.
Just a comment to what was saying by Pietro. In the fact that for resecting a patient with liver metastasis from breast cancer, he should be convinced by the oncologist. I would say it's a reverse attitude. We have now resected more than 200 patients with breast liver metastasis with a policy very simple. Patient very well controlled by chemotherapy, and oligometastatic disease. We will not go into a half procedure for breast liver metastasis very simply. And so by this way, what we show is that we have a 42% 5-year survival, and we have long-term survivors. We have now 15 patients alive, disease-free at more than 10 years, which is impossible to obtain with only systemic therapy. And for me, this is the most stronger factor encouraging me in proposing a liver surgery for oligometastatic breast, well-controlled disease. And so I don't need to be convinced by oncologists. What we need is to convince oncologists to refer such type of patients.
We all agree. We all agree about that. The point is, you showed, nevertheless, that the biological status, and particularly RR are really important in the prognosis. My question is, if you have a patient positive, RR negative, do you contraindicate her to surgery? Because it seems to be a very important factor.
Yes, you're absolutely right. It's a very important factor. But so far in our principles to indication to the surgery, we did not take it into consideration. Okay. That's a kind of a pilot study or a pilot indication.
That's the limit of those studies. Okay, Rashad.
Thank you, Christophe, for your excellent presentation. I'm not going to comment on it. It's just the first thing about the incidence. The incidence has changed. According to the WHO, since last year, breast cancer is #1 in the world. #2 is the lung cancer. And then as a cause of death, breast cancer has moved from the 2nd cause of death to the 5th cause of death from cancer all over. And that's because #1, early detection. #2 is multimodality treatment.
I appreciate your comment.
Thank you both.
Both, yeah.
I'm sorry.
We have a little time, so it is possible for anyone who has a talk tomorrow but is ready to give it now, we can accept that talk. If anyone wants to volunteer to do that.
Ready? Philip? I can volunteer. It's
Hugo.
It's not a talk, it's a film. It's good to finish by a film. You have a wonderful film with a lot of anastomosis, as usual. You want a lot of anastomosis
You want to do 2
and
or 1?
pancreatic surgery? You want? Okay, we finish like that.
Yes, okay, come.
We wait for you. It is in the box? Okay, it's ready. So,
we ask
probably.
yeah, we need
Probably. Yes. No, this is one. Who is this? Who is this?
I
Who
think
is this?
Hugo is also ready.
Hugo, Philip, maybe I can move the program of tomorrow today, or by night. Okay. With pleasure, Philippe Bachelier's the modified, extra modified Appleby technique for locally advanced pancreatic adenocarcinoma.
Hello, everybody. No, not yet. Not yet. After the video, maybe. First, where is Guido? Guido is not here. I thank you very much, my good friend, for these invitations and the opportunity to relax the audience by this video. So, not yet. Yeah, okay. No, we can stop it. Yes, little bit. No, I just want to say one word before we start the video. As you know, locally advanced pancreatic cancer could be treated in selected candidate by surgery associated with chemotherapy, preoperative or postoperative chemotherapy. And the difficulties, the concern with this surgical procedure is very linked to the obstruction of the venous system, portal system, mesenteric vein, and so. And the main details for this procedure are linked to the resection of the pancreas without ischemia of the liver, and ensuring during this dissection the portal inflow and the outflow from the bowel, and the reconstruction of the venous. Because my opinion now, after experience, to resect or reconstruct an artery is very easy. You need a stump, a proximal stump, a distal stump. It's very easy. You stitches the both sides. But what is very, very important is the venous drainage. If the venous drainage is not efficient, you have a venous thrombosis. If you thrombose the vein, you occlude the artery. That's very, very, very important. So that we develop, like as a Japanese surgeon, we develop a shunt. And we will see on this video an example of this procedure using for Appleby technique transitory mesenterico-portal shunt. So we start with the video. I think here. Yes. You will see the detail of this patient. It was a young woman, 46-year-old, with a huge tumor you can see here of the neck and the body of the pancreas. And we decided to do this Appleby procedure. So when there is a blockage of the venous axis, we are used to mobilize all the colon on the left side, on the right side, and mobilize also the block, duodenopancreatic block. So you can see this dissection here, the right colon and the duodenum, and we free all the tissue around the duodenopancreatic block. So here, dissection of the superior mesenteric vein, just below the tumor. The tumor is located just above my finger here. We located the superior mesenteric artery with, we spot it here, you can see. And after that, we do the dissection on the top of the neck of the pancreas, freeing here the gastroduodenal artery and the distal part of the hepatic artery. We put a tape on these arteries. So we do a cholecystectomy just to have a look on the hepatic pedicle. Here we mark and we tape the hepatic artery in order not to cut it during the dissection. And we extend the lymphadenectomy to the left part of the pedicle, hepatic pedicle. So we tape all biliary duct and hepatic artery just to have a good space on the portal vein. So we measure the diameter of the superior mesenteric vein to choose the good shunt. We use ringed Gore-Tex to do this shunt. You can see it, the white tube. And we implant this Gore-Tex on the proximal stump of the superior mesenteric vein. We do the stitches, the suture, end to end, using proline. That's very common. And we put this shunt, we close the stump, obviously, and we put this shunt out of the operative field. Usually it is on the right side, as you can see, and we implant the top of the prosthetic graft, the Gore-Tex, into the lateral side of portal vein. As soon as we did that, we can unclamp, and we never mind during the rest of the operation about the drainage of the bowel and the vascularization, portal vascularization of the liver. So, in this patient, she had operation for varices on the legs, so that saphenous grafts were not available, so that we decided to reconstruct the hepatic artery with a segment of splenic artery, as you can see, with it's a distal segment, of course. Here we have cut venous, the left venous gastric vein, and we taped also the artery. And now we cut the neck of the pancreas, but at the junction between the neck and the head. So we are just on left side of the gastroduodenal artery, as you can see, just on the top of the right angle. So doing that, we reach here, we can join the proximal part of the portal vein, just above the venous confluence. We tape it, and because we have done this shunt, venous shunt, we can here, as you can see, cut with a stapler the portal vein. We do that. So now we can do the dissection around the different arteries. There were no involvement of the SMA in this case. Sometimes there is, so that we have also to resect and reconstruct the SMA. And afterward, we do the lymphadenectomy, and we remove all this lymphatic tissue around both arteries. Till the aorta. So we use this device, which is very convenient for coagulation and sections at the same time. So this dissection, we remove all the lymphatic tissue and the splanchnic nerves between the celiac trunk and SMA. Here we individualize the left adrenal glands, and we mobilize also the splenic and left pancreas en bloc. We cut the omentum, the left part. And in this technique, which is a modified Appleby technique, we keep the stomach. I remind you, the Appleby technique is already, we call that Appleby technique in the pancreatic resection, but it is already a modified Appleby technique because we keep the stomach. In this extra modified, we also resect not only the hepatic artery, but also the venous axis. So you have seen the different dissection. Now, to reconstruct the venous axis, we decided to use the left renal vein. We remove all the tissue around, and we clamp and cut this left renal vein just downstream the adrenal vein and the genital vein. So that very often there is no need for venous drainage of the left kidney, and it is efficient. So you will see at the end of the video, we will test the tension into the stump. If there is too high tension, we have to implant this renal vein into the inferior mesenteric vein. So before to reconstruct the vein, we reconstruct the arteries. So we cut the left gastric artery. We cut also, after clamping, the common hepatic artery. You will see here arterial flow. We have further to maybe to discuss about the necessity or not to reconstruct these arteries. Sorry? Not yet. I discuss now.
Okay.
Thank you. Yeah, comment after. So, now see, if we do that, we will lose something. Okay. We cut here the proximal stump of proximal part of the celiac trunk, and we finally remove the specimen with en bloc resection of the confluence of the venous confluence and celiac trunk and hepatic artery. So, as decided before, we reconstruct the hepatic artery using this segment of the autologous splenic artery. It's arterial anastomose. We use stitches X0, Coralline X0, using loops, not loops, magnificent glasses. We do that with the first one. and we implant the distal part of this graft into the stump of the hepatic artery, as you can see here. Same technique. After this arterial reconstruction, here you can see we kept a branch of the splenic artery, and I decided to cut this branch and not to implant into the left gastric artery, because when we reconstruct this artery with a good diameter, you can see here, there is a pulsation, good pulsation. There is no need to reconstruct left gastric artery. So the time is now for the reconstruction of the vein. We clamp here the portal vein. We cut the stapler line. And during all this time, there is always a portal inflow in the liver. So doing this technique, we reduce significantly the time of clamping for the venous resection or reconstruction. So we reconstruct using the left renal vein graft. It's a common suture, end-to-end, using also Proline 6O. And what is important when we do that, we have to do some mark on the, you can see the color, the blue color on the vein, to put on the right, and we do a frozen section on the cutting edge. So now we reconstruct with implantation of the SMV into the left renal vein. And now there is a clamp. We have to clamp. The shunt is not functioning, and the duration of this occlusion of the SMV, so the portal axis, is about, it's a time to reconstruct, it's about 15 minutes. So now it's finished, and we have to remove the Gore-Tex. We unclamp the portal vein, which is reconstructed, and we have to remove the Gore-Tex on the right side of the portal vein. It is a lateral clamping without any occlusion, as you have seen. So you can see here the stomach. We test the tension on the stump of the renal vein. Here it was not in tension, so that we decided not to implant in the inferior mesenteric vein. We test with ultrasound the quality of the artery, hepatic artery, and we finish with the drain. So we usually do at the day, postoperative day 1, a CT scan just to check if there is no thrombosis of the arteries. You can see here. And 1 year later, there is also artery patent, and what is most important is there is patency of the venous axis, which was reconstructed. This patient was operated in 2021. She's still alive, but recently appears liver metastasis. Thank you very much for your attention.
Thank you very much. We have some questions.
Professor,
Microphone.
Congratulations for the amazing surgery. Just one technical issue for my learning. Why do you harvest the left renal vein and you could use the prosthetic graft you had already in place with one of the anastomosis done already?
I don't like prosthetic graft because the patency, there's many publications about that, of the length of the patency of the prosthetic graft when we reconstruct the portal vein. And after 6 or 1 year, it is occlude. So when we do this kind of surgery, my ambition is to maintain alive the patient for long. We don't have time to discuss about survival, but in our experience, we have now for the patient without oligometastatic disease, more than 170 patients, we have a 5-year survival, which is 40%. So 5 years, it's not 6 months, it's not 1 year. And if there is an occlusion of the vein, there is a lot of consequence. You know that very well. For the bowel, there is a discomfort and hemorrhage, maybe. So we don't use prosthetic graft. We have to use something because when you resect the confluence, you resect the minimum, the minimum length of the vein is 3 centimeters. Between the two stumps, portal stump and mesenteric stumps, there is the head of the pancreas. You cannot pull. So that you have to use something. The solution was described by the Japanese author using this left renal vein. And when you use the left renal vein, you have to check, as I show you, if there is tension or good drainage of the left kidney. If there is no good drainage, you have hemorrhage on the left part of the retroperitoneal. So that it's very inconvenient. The second possibility, if you want to use a biologic tissue, is to use a saphenous graft. You do angioplasty, a tube like Lee described for the hepatic vein, or cryopreserved tissue. But this kind of tissue are not very common because and not very good because there is also as a graft thrombosis. So we try to use a renal vein or saphenous vein.
Okay, thank you. So Pietro?
If the stomach had not been in good shape, what you would have used to reconstruct the artery?
Yeah, it's a good question. You know the big series of the north in Europe with no reconstruction of the hepatic arteries. There was what was the question?
The question is that one of the risks of this procedure is having to cut the left gastric artery, then not having the spleen and then the stomach living on what? On the right gastric, and it's very little. And the Japanese have described reconstructing the left gastric on the middle colic.
Yes.
What do you advise?
Yes, in this case, we had the opportunity to reconstruct, as you see, because there was a branch, and my first idea was to do that, but it's difficult because the left gastric artery is very, very, very small. If you increase the number of arterial anastomosis, you increase the risk of thrombosis. So I think the most simple is more efficient. So we we look at the end, after reconstruction of the artery, we look at the color of the stomach, and especially the high parts of the stomach. If it looks gray, it's not good. You have to do something else. But what is very, what we observe very oftenly is this gray aspect of the stomach, of the high part of the stomach, when we have clamp or remove during the time of removal of the hepatic artery, and it vanished when we reconstruct the hepatic artery. Because when we do this technique, we keep the pyloric artery, and we keep also the gastroepiploic, the right gastroepiploic artery, so that when there is a good inflow into the hepatic artery, there is no need to reconstruct the left gastric artery. In the experience of the Japanese surgeons, they don't very often reconstruct the hepatic artery, so that they have to reconstruct the left gastric artery. It's very important, because if you don't reconstruct one of these both arteries, it's not sufficient to arterialize the stomach. So the first, I remind the history. The Appleby was described by a Canadian, if I remember well, surgeon, and it was applied for gastric cancer involving the pancreas. So he removes both. If you keep the stomach needs a lot of blood. So you have, in our policy, we systematically reconstruct the artery. And we don't mind if it is closed or unclosed, and so on. We don't do embolization. We systematically reconstruct the artery, hepatic artery.
The question was in the same line that Pietro. How do you check the safety vascularization of the stomach? But you already
with the color. With the color.
The color.
Recently,
sometimes the venous return is not good. Maybe the artery is the color, but the venous deprivation.
But you have seen there was big vein on the stomach. These big veins, this dilatation was induced by the portal hypertension, induced by the occlusion of the splenic vein. So there is big vein. But at the end, the venous drainage is done by the top and the low part of the stomach.
Great.
And we now
for this fantastic video.
But recently we bought a new Doppler. It's a Medistim. It's a special for the vascular surgeon. It's a very small sound, and it's very convenient to check the flow into the artery which was reconstructed.
So maybe you will not reconstruct systematically the artery, the hepatic artery, with this device.
Maybe.
Why do you?
Yes,
are you ready to discuss that?
Maybe, but I don't want to play Russian roulette with the patient.
Why? There is the gastroduodenal, which is, look at it, when you cut, there is an excellent outflow, pulsatile outflow. No. It doesn't need, you said yourself, if you do anastomosis, the risk of thrombosis.
Yes,
so you create the risk of thrombosis.
As René said just previously, we have to convince everybody that is the right way. No, I think we can do a study if you want. You cut the left pancreas without reconstructing.
That's why I'm doing.
Systematically.
That's why I'm doing Appleby. If the gastroduodenal is good, I do not reconstruct the hepatic artery. Maybe I have not your experience, but for the moment it's good. And Del Perro, your friend,
yes,
is doing an embolization of the hepatic
I
artery
know.
before to improve the outflow by the gastroduodenal. So I don't know, it's really useful, but it's Del Perro, not me, Del Perro.
Yeah, I know him. But
do you?
But even the Japanese surgeon don't
They reconstruct, Japanese surgeons?
When they do embolization of the arteries, the results are not so good. I discuss with them, it's not so good. So very, very often they have also necrosis of the stomach. So I think the best way, it's my opinion, you resect an artery which was not occluded, you have to reconstruct the artery. The results of the embolization before operation, I think there is a too short time between the embolization and the operation, so that there is no time for a good arterialization from the gastroduodenal artery. We have now, we can study that. Probably in the next patient we will do systematically the use of ultrasound with the results of the measurement of the pressure. So maybe.
Philippe, great operation. Just one observation. I use as biological graft internal jugular vein, autologous internal jugular vein. Do you have some experience about this? Because it's longer, it's almost the same caliber between portal and mesenteric vein, and I find it very useful.
We did that before. It's a good graft, very good graft, good, longer than the renal vein. But doing that, you have to push the anesthesiologist. So it is a major inconvenience. So
I push the anesthesiologist before the operation.
Yes, but
so I prepare already the neck.
If finally, when you open, you discover carcinomatosis and you cancel the operation, you have removed the vein of the patient?
No, because I take out the vein once I'm sure that it is resectable.
Yes, but it's not very convenient.
Okay, we'll just quickly, Pietro, because Hugo's giving the last talk. Yeah.
Yeah, on the last line, a good option that our vascular surgeon in Geneva used is the superficial femoral anastomosing the distal bit to the deep femoral.
It's also a good option, yes. Yes, I agree.
Thank you, Professor Bisciali. Excellent.
Thank you very much.
Yeah. Okay, we have the last talk for today. Hugo is going to talk to us about robotic surgery for perihilar cholangio.
Let's change a little bit, if this works.
Yes, it is.
And that I have to switch because...
Okay.
Let me check if it is running.
Okay, so we move to this other completely different topic. I would like to thank Professor Bismuth and Guido for the opportunity to present our work here. And we are going to talk about robotic hepatectomy for perihilar cholangiocarcinoma. As you know, hilar cholangiocarcinoma is often regarded as a tumor in a very difficult location because it's located near the bifurcation of the portal vein, near the right branch of the hepatic artery, and in fact, it is often referred to as extrahepatic, to the biliary confluence as being extrahepatic. But in fact, if you resect the biliary confluence, you are deep inside the liver. So in fact, the biliary confluence is not at all extrahepatic. So hilar cholangiocarcinoma is a parenchymal disease in a location with difficult access. As you know, of course, the most adopted classification for hilar cholangiocarcinoma is the Bismuth classification. You know there are 4 types of clad skin tumors, but in fact, Professor Bismuth has even described a 5th type that is very difficult to find in the literature, but often referred by Professor Bismuth as a 5th type that spares the second branch order of the left confluence, spares the branches for 2 and 3. This is an example of Bismuth type 3A hilar cholangiocarcinoma. Perhaps due to this location, the only approach that has ever been considered for perihilar cholangiocarcinoma is the open approach, is the approach that is most widely used. There are some reports of some very scarce experience of laparoscopic resection of perihilar cholangiocarcinoma, but in fact, it is very, very rare to see this type of descriptions, and they are probably much more difficult to approach than by the robotic approach. And using the robotic approach, we have some advances about donor hepatectomy being done by the robotic approach. Fabio is going to speak to us about that tomorrow. Reports of vascular reconstructions being done by robotic approach, and also some small series of hilar cholangiocarcinoma resected by hilar approach. This systematic review summarizes a total of 109 patients in the whole literature in robotic approach. And as you can see, in fact, there are very few reports of series of robotic resection of hilar cholangiocarcinoma. There is only one series in the Western world reporting hilar cholangiocarcinoma being treated robotically, and there are several series from Asia, but in fact the largest series show that in 21 patients, in fact only 3 of them were treated by liver resection. In the Western series, there is an Italian series of 4 patients. In fact, in those 4 patients, in one there was a conversion, but we can see that apparently the results show that this is at least feasible, and with a post-operative stay that is probably shorter than in the open approach. If we look at our own experience in Lisbon, we can see that this is the total experience of our activity in HPB surgery, and you can see for liver surgery the numbers of last year's, 471 patients operated last year, and you can see that the percentage of patients that are operated by the robotic approach are increasing. And you see here, for example, that when we started the program in 2019, we started by simple operations, anatomical segmentectomies, right or left hepatectomies, and then we moved to more complex operations like mesohepatectomy, reconstructions and resections and reconstructions of the bile duct, and then we started performing surgical treatment of Klassken's type 3B and 3A, and after that, portal thrombectomies and even IVC thrombectomies. This is an example of a patient with a type 3B hilar cholangiocarcinoma, and I'm going to show you this video for you to see that, in fact, we can replicate the technique that we are using in open surgery. This is clearance of station 8 around the hepatic artery, the common hepatic artery. This is clearance of station 12. Then we can see here clearance of station 13. This is a classic place of recurrence in perihilar cholangiocarcinoma. This patient, as many others, have right and left replaced hepatic arteries, so it's frequent to have this type of variations, of course. Now we are approaching the bile duct and sending bile duct to frozen section. We are using internal external drainages now. This is distal bile duct. Right replaced artery from SMA, common hepatic artery. This patient has also a left hepatic artery for the left liver, of course. So we are sectioning the common hepatic artery. This is the left branch of the portal vein. Then we cut the left branch and we continue the resection. And we do at this time, at the same time, lymph node clearance and dissection of the hepatic pedicle, because we feel that this is, in fact, the best way to gain some time in this operation. Clearance of station 7 nodes next to the left gastric artery. This specimen had 14 lymph nodes. This is the common hepatic artery. This is mobilization of segment 1. The common trunk of middle and left hepatic vein is taped for orientation of the resection. We see here. And we have two options. We could do a left extended hepatectomy or a left resectionectomy. We opted for a left extended. This will give us probably more ducts to reconstruct, but as long as we have a clear margin, it's a good option, we think. And this patient was resected. The liver resection timing was one period of 15 minutes of pedicular clamping. And we are approaching the bile ducts on the right. And we are cutting, as you see, the bile has good quality, fortunately. It's not an infected bile in this patient. Frozen section of the proximal bile ducts. We have 2 ducts here. And finally, we continue the hepatectomy in the right plane for a left hepatectomy. We gained again the plane of the middle hepatic vein, and we staple and separate the left extended hepatectomy specimen, and then we reconstruct a Roux and Y for the hepaticojejunostomy that we do in transmesocolic, although it can be done anticolic. It depends on the patients, of course. And then, in this case, we had 3 ducts that we could reconstruct in a single hepaticojejunostomy. And this is one of the main advantages of the robotic platform that allows us to perform this type of reconstruction, in our view, much more easily than if we were doing, for example, a laparoscopic approach. So the posterior part of the anastomosis. Then we have the anterior part. And one of the advantages is, in fact, the improved visualization that we have with this type of technique. We can see here 13 lymph nodes, 4 positive. It was 2-A and 2. So, in fact, the thing that impressed us the most with the first cases of perihilar cholangiocarcinoma was the post-operative, because there is less, we see much less complications in this type of patients when we compare them with the open approach. And you can see that if you compare the 6 first patients with 6 patients done by the open approach at the same time, in fact, one of the most striking things is the hospital stay. But, for example, the bile leaks are very infrequent in this type of approach. So now, and we have also our co-author Fabio here, this is the first paper on perihilar cholangiocarcinoma for robotic approach. It's the first multicentric series that was done. It's not published yet. This is the preliminary paper, and you can see this was done with Lisbon, Modena, and Tampa. 9 patients in Lisbon, 13 patients from Fabio de Benedetto here in Modena, and 16 patients from Tampa. And you can see that, of course, the operative duration is long, 481 minutes median. Estimated blood loss is very low, in fact, 200. We had 1 unplanned conversion, and we had 5 type 4 hilar tumors. The most frequent operation performed in this series of 38 patients was left extended hepatectomy, although we have 11 cases of central hepatectomy. This is unusual. This is the option they took in Tampa, in Florida, to treat type 1 and 2 patients. And that is why there are so many patients with central hepatectomies for hilar cholangiocarcinoma. You can see the number of lymph nodes harvested, the median number is 7, and we can see that 2 patients had vascular resection and reconstruction. 81% of the patients had R0 resection. For complications, we had 6 patients with grade 3. Median length of stay was 6 days, which I think it's very, very good, and we had 1 patient with mortality. This is some of the first cases of vascular resection for perihilar cholangiocarcinoma performed robotically in our knowledge. This is our case in Lisbon. It was a type 3A. So in this patient, the discovery of portal vein invasion was intraoperative. You can see here the specimen with 22 lymph nodes, and we can see here the lymph node clearance, where you can see all the vascular anatomy of the region. Now you can see invasion of a portal vein. We are performing the right extended hepatectomy under Pringle in this case. And then we are arriving to the left bile duct that we can see here. And we are now first doing a section of the left bile duct. We are doing frozen section, of course, and then we go to the portal vein resection, which is the last part. We decided to use a stapler. This was not an excellent idea because we lost some length, and so the anastomosis was a little bit more difficult, although not at all impossible to do. And this is the reconstruction using 5-O-proline. So the posterior part of the anastomosis is almost finished. We are now in the anterior part. And you can see the final aspect of the portal vein after reconstruction that you can see now. After this, we have the ductoplasty and the reconstruction with the ruined Y. And finally, this is the final part of the operation and the Doppler confirming good flow. So I took the opportunity and I asked Fabrizio to show me his own video from Modena for type 3B. 3B, yes. So we can see here the portal vein resection using clamping. Fabrizio decided to use a clamp in the upper part. I think it was a smart decision because he had a little bit more space to reconstruct. So cutting the portal vein and then the main trunk. And then you can see the reconstruction. Posterior parts and then anterior parts. And this is the final aspect, and you can see unclamping of the portal vein. That's it. So in the first experience, we can also present a preliminary survival for those 38 patients. And you can see that, in fact, the survival of these patients is above 40% at 5 years in this first multicentric series. And I will finish saying that, in fact, world experience in robotic liver surgery is still scarce. Surely there is more data that is necessary to allow an adequate comparison with open, and why not with laparoscopy, but I think open much more important. And hilar cholangiocarcinoma being done robotically is an experience that should be reserved to highly experienced centers, but it looks to us that this is probably one of the most promising applications of robotic surgery. Thank you.
Fantastic, Hugo. We're going to ask you to stay there. We won't do the discussion just yet. We have the honor of the chairman or CEO of Humanitas, who would like to say a few words to us. So I'd like you to welcome Mr. Rancharo Rivera. Thank you.
Yeah, good afternoon to all of you. And sorry to interrupt you, but I really want to thank you, all of you coming here. I mean, all the people who contributed to the organization of these days. I thank Professor Bismuth and Professor Torzilli, and I'm happy to, on behalf of Humanitas, to thank you for this event. And I guess, I mean, this is really in the heart of what we do every day here in Humanitas, trying to combine high complexity care, high complexity surgery, research, and teaching. So growing new surgeons, growing new medical students, new physicians, trying really to do the best for our patients and possibly for this country being in Italy. Thanks a lot to all of you.
Okay, Hugo, can we have you back up? Yes. Okay, I'm sure
Hugo,
that's going to...
brilliant presentation, excellent surgery. 2 questions. We consider actually all the clad skins, they're all mostly drained with drains, so we consider them as infected, and we treat them from 1 day before till 7 days, blinded, just always broad spectrum antibiotics. Do you also do that? And secondly, second question then, we also have the vision that sometimes you do portal resections, sometimes you don't. We have a little bit Peter Neuhaus from Berlin. We always do a portal resection, almost always. Or it should be really free. And otherwise, with a little bit of doubt, we just cut it out, always. What's your opinion about that?
Well, I think these are 2 important points. First of all, infection is probably the reason why most patients die after this type of operation. And some years ago, we started a protocol of active detection of infection preoperatively. So we culture the patients preoperatively, and we do blind antibiotic therapy after day 5. And every 2-3 years, we reevaluate the results to adjust antibiotic therapy to these patients. I think at this time it's ceftazidime and metronidazole, I'm not sure, but we are always changing. And this had made a huge impact in the post-operative period of these patients and the post-operative results. On the other hand, for portal vein resection, I think the preliminary results of Peter Neuhaus were never reproduced. And so to do a no-touch resection without evidence of invasion is not our policy now. What we do is, as long as we know that we have portal vein invasion, we plan a no-touch resection. But we never do it on purpose in a patient that has no portal vein invasion known previously.
Yeah, Dimitri, please, yeah.
Hugo, I want to congratulate you so much. How far you have come from the first couple of cases that we did together in Lisbon to now. It's just absolutely impressive. But I just want to echo a lot of the things that you said, because the visualization of these tumors is better. The lymph node harvesting is more precise, and I think the numbers are higher with the robot. And your oncological R0 resection level is higher with this approach, because the way you visualize and the way you're able to reconstruct these bile ducts robotically with magnification almost over 20 times bigger, you have an extreme precision, which leads to less complications, shorter hospital stay, and overall better oncological outcomes.
Totally agree. I think this is one of the main advantages, yes.
May I say something? Of course. Scientific. Professor Bismuth, I learned one thing from you also. That's the obligation that we have, all the companions, when we leave and when we go, because we finish our activity, to give opportunity to the people who stay to do better sorry. So I am very proud, because this robot was the first robot for a public hospital in Portugal. And I fight for this robot when I was 69-year-old already. And I knew that in 1 year, I went out. And that's not the reason not to fight, to give to Hugo. And I am very proud now to see that's one of good things that we can do. That's for our teams and for our groups. That's to give opportunity to people who are going to stay, to have the conditions to do even better. And that's the message, that's the responsibility that I think that Compagnons have also to have this. So, Hugo, I think that's a good idea. And I went to Pakistan to have this robot 1 month after I have my heart attack with the 2 stents. So I have the protest not to go, but I went there, and okay, that's that message I want to give you.
Thank you. Yeah. Hugo, you said, your last sentence is that the robot is necessary, and you think has better result than open surgery in this very complicated, extreme liver surgery and biliary surgery. What do you mean? You mean that we HPB surgeon, we need now to introduce the robot in the extreme part of our technique?
Yes, I think so. I think the 2 main messages I wanted to say is, first of all, it seems to us in this very early experience that this may lead to better results in this particular group of patients. We see this in the post-operative period. We think so. And on the other hand, we think that every HPB center, every specialized and referral HPB center will probably have to have a robotic platform in all the armamentarium that they have, because I think this is a very important tool, probably for this type of very advanced surgery.
And you say it seems to you to be better than laparoscopy, and you say better than open.
I think it is better than open in some cases, yes. We
think?
Yes, I think that for reconstruction phase is better compared to the laparoscopy, but usually we perform the liver resection in perihilar in very selected cases, not in all cases. So in my center, we perform only 13, up to now, 18 cases. but usually we perform in open, with open technique. In very selected cases, we perform with the robot, the liver resection and reconstruction. Not in all cases, in my center. Because usually, as you know, Professor Bismuth, the patient had very advanced, so.
What are the indications of open surgery now?
In my center, portal resection usually is indication to approach this patient in open way, and very, very complicated cases like portal and artery infiltration. So we usually approach the patient with the robot in very selected cases. But if you do artery resection and portal vein resection, we can do open in all patients.
We have to say that.
You know, there was one case reported of robotic liver transplantation. Not only the donor, but also the transplant. We are very, very reserved. And you know the reason.
You are right. I think that you are right in this is an initial experience, Professor Bismuth. So we have this is a 3-center, 38 patients. So this is an initial experience. So we have no data, but usually the classic way, open way, is the best for me and for the moment, for all patients. So the liver transplant is also living donor liver transplant, and whole liver is very promising indication. And the robot in my center for Pekolj, we use usually to do a lymphadenectomy before liver transplantation. So it's very, very interesting to use the robot because it's very easy compared to laparoscopy in the setting of liver transplant. So I totally agree with you, and I think that we stay at the beginning of the activity to approach the Pekolj with the robot for the moment.
I can say, for example, for now that we have probably the same numbers. We should be reaching 20. And what we are doing is like we are starting to propose more and more patients for the robotic approach. So we were being very restricted at the beginning, and now we are starting to be a little less restrictive. But we are still putting the worst cases in open, of course.
For example, for now, we have no idea in the seeding after the mini-invasive approach. If you look at the literature, we have no data about the seeding inside the abdomen or at level of the trocar in abdomen or at hilum. So this is a problem for us because we will see in the next future if we have the same problem like in open.
I think that my avatar will start doing robotic surgery in the metaverse.
Okay, thank you, Hugo. We'd like to bring it to a close. Thank all the speakers, the discussants, and all of you as well. Guido, is there any announcement for tonight? The bus is here, but for tonight, is there any announcement for the dinner?
Where is the dinner? 12.